12:18, and I am going to call the Water Quality District Board to order. And first order of business is, perhaps been a long time coming, but nonetheless, we want to recognize Peter Nixon's service at the City County Health Department and the Water Quality District. And I think Alan's going to say a few words first.
And I hope you all do. I won't make this as long as Garen's because we're actually going to have an opportunity to spend more time praising and teasing Peter at a gathering that I believe is more than tentatively set for Thursday evening, April 12th, starting at 5, Darlington Lawn and Robinson, top floor. So you'll all get an invitation. We hope you can come by. But for the moment and for the record, I want to thank Peter for all of his incredible service in the community, the environment, the innovations. I can't talk. I'm not crying, Peter.
I'm just so
I don't know. Innovations, science, persistence, nuance when needed, pushing when needed. He has, everybody has a legacy. Peter's is really on the ground. You can see it, or in some cases you can't see it because he made it go away. So it's been a lot of fun, and I'm just really proud to have worked with Peter and been a part of that.
Thank you all.
If you'd like to come up and just, like I said, we're going to be a lot meaner when we do get together.
Oh.
And I note the tie.
It's off camera.
I do note the tie.
Well, I thought I should not wear jeans.
That's right, I dressed up.
But I'm very thankful for the opportunity to have been part of this wonderful ride over the past 26 years, and the support that the board has provided for the Water Quality District work. The work we do at the Water Quality District has been very strong and very much appreciated. For everything from our work on White Pine Sash in the early days to Milltown and Smurfit and other things that we've done together. We've been incredibly supportive of the mission of improving water quality in the Missoula Valley. And really, I think this community is, I've said it before, this community has done more than any in Montana, clearly. And probably for the size of this community, more than any in the country, to protect its own water resources. And establishing the Water Quality District as a means of establishing local control and ability to manage those things at the local level has been a big part of that. And I'm just really thankful for the opportunity in that part of it. Thank you.
Yeah, Peter, I mean, you mentioned a few things there, high profile ones that people can see on the ground. I think those other underground things, the sewering of, Linda Vista neighborhood and the Rattlesnake neighborhood, I mean, those things are big, huge gains for the water quality, safety for all of us to enjoy. And I think that, you were instrumental in those pieces, and also for helping, get funds set up to help people get sewer connections and actually get connected to this system. I think that, there's so many things over the years, and just, on behalf of the board, thank you for everything that you've done over the years
Appreciate that, Debbie. Thank you.
to keep it moving.
So can I ask, what's on the plate after retirement?
Oh, I have a lot of interests. So there are a lot of things that are possible to do. I'm not planning to take another job or anything like that. So, but I'll be staying here in Missoula. And, I have a lot of things to do. So,
To be continued.
I'll do whatever I want now.
As long as you don't plan on dumping any, used motor oil or storm drains or anything like that.
Yeah, I won't do that.
We can always use volunteers at Has Waste Days, so maybe we'll see you in September.
Well, the one thing that is gone is what we used to teasingly call Peter's poison pond of pike behind the Milltown Dam. So, in fact, it's 10 years this month.
10 years this month.
It has been
2008.
10 years since the breach.
Wow.
And I remember you traipsing along with me to Wisconsin, and thanks for being a good sport and doing that, and learning about, in the early days, and learning about what
Dam
dam
removal.
removals were really about,
Yep.
when everybody thought it was a completely crazy
Baraboo,
idea.
Wisconsin, whoever heard of that place, right?
But, you know, the other day I was renewing my license plate over at the courthouse, and I had one of the river plates, you know, and I kind of teased the guy. I said, "Wait, do you know anything about this?" And I said, "Oh, it's some fundraiser for some group." And, "Well, there used to be a, did you know anything about a dam? I said, there was a dam?" Yeah. I said, "Where was it?" Well, I had no idea. So people soon forget.
They do?
And what was all the fuss about, really?
Right.
It seemed like a lot of meetings that were kind of stressful there for a while, but it's all clouding over now, my memory.
Or clearing
It's a
up.
good thing about getting older.
But thanks, Gene.
Yep.
Anyone else? Thank you.
Thank you so much.
We'll get you on the 12th.
Next up on the agenda is approval of the February 15th minutes, which we do have in front of us.
I'll move that we approve the minutes.
Oh, thanks. I watched it.
We have a motion on the table. Is there any public comments on the motion to approve minutes? Any staff comments? Board or staff comments on the minutes? Hearing none, all those in favor say aye.
Aye.
Same sign for opposed. Motion carries. Shannon is up for agenda item number 3, update on household hazardous waste facility.
Really, what I'm going to do is talk about a lot of work that Peter's been doing that is really going to help us figure out our next steps in the household hazardous waste facility. So a lot of really great, exciting work was accomplished this year. Peter, just like when he went to visit the dams, what he did is he went and looked at hazardous waste facilities, not as far as Wisconsin, but and found one in Asotin, Washington, which is Clarkston, really right on the border of Washington and Idaho, that worked particularly well. He looked at several, but I think that is what our facility is pretty much going to be, kind of structured on. Then he worked with Gavin Hanks Architects to really put the building together. The building has a lot of great features. It has different bays for reactives and flammables and corrosives and pesticides, and each one of the bays has its own containment system. So if there's a spill, it will be captured just for that bay. It won't mix with other. If we have like 7 spills all at the same time in different areas, they won't intermix. And there's a chemical fire suppression system, a lot of safety features. There's an office and a little bathroom. There's good ventilation. Did a lot of thinking about all of those things, about how it would work. For those who are newer to the board, we have done household hazardous waste collections for about 24 years. It's a once-a-year event. It started out as kind of a crazy painted mess. We took latex in the early years, and we were really covered with latex by the end. I'm not sure how that happened, but through the years, Peter has insisted on and implemented a number of things to make the event safer. We stopped taking latex. It wasn't a hazardous waste. We even did a research paper on it to investigate whether we should take it or not. It just wasn't a good use of the money. But Peter has long thought that it just wasn't the safest way to do it. We got a lot of people, short amount of time, we're working hard and fast, and to have a permanent facility will certainly be more convenient for people. You know, a lot of times people want to get rid of stuff when they're moving out of their house, or they've just moved into a house, or they're helping their parents move out of a house. And they would always have to wait until the fall in order to do that. So we think that we're firmly behind the idea of a permanent facility, think that that's the way to go. We'd probably be open a couple days a week. And based on what Peter has found in other locations, feels that we would take the same amount, perhaps a little more stuff throughout the year, but it would be done in a more measured fashion. And we wouldn't store the amount of waste that we collect at every event. It would be picked up on a routine basis, and there's also better opportunities for reuse and recycling than we can do in our kind of, I don't want to say that it's frantic, but it's, a very busy event when we do that. We really had gotten pretty far with it, but just as we were getting ready to pull the trigger for going out to bid this year, it was getting later and later in the season, and apparently I have not built a building before, but apparently it's really important to do that in the winter so that you could get good bids. But as we were getting close to that point and having all the plans ready, a couple of things came up that would delay it further, and so it just got to be too late to put the bid out this year. So we chose not to do that. That gives us an opportunity to also look at another site. It seems late in the game to look at another site, but we have two now that are in mind. One is on Scott Street. It's on the way to the landfill, which is great, but it's a neighborhood that's more residential, has more development planned, where they're trying to kind of reduce the amount of traffic. This would maybe put in more traffic, and it's not that incredibly convenient for all parts of Missoula there. We were concerned, there's a park right there. The park it looks like might be moving, but we're concerned about odors. And there are fixes for these things, and we've looked at it, and honestly, if we end up at that site, in the end, we've talked with a lot of people. We talked with the Parks Department about how to make it look good and how to make sure we don't have any nuisance odors. It's a very secure building, so that all feels good. But there are some extra steps that we still need to take if that's the site. The other place that we're looking at is the junk vehicle yard. There's an acre behind the junk vehicle yard. We would actually have to build a road. So we said, we're not going to do that. But there's kind of 50-50. Either we put money into a road and we think that we can get some help from the neighboring landowners because they have interest in having a road there. Or we put the money in a longer service for water and sewer. So the nice thing about having it at the junk vehicle yard is it really is pretty easy access. The junk vehicle yard is on Dayshaw Lane. It was like right next door to where the old movie theater is, the old drive-in theater. It's easy access off the freeway, and it's in an entirely industrial area. The other nice thing just for us as the health department is, first of all, the county owns that land. Second of all, right now we have a junk vehicle person who works out there moving cars around, draining cars, and works out there entirely alone. So to have a person on the other side of the fence would give us there's some safety benefits there. And then there could be some cross-training and cross-work between those two people, between the household hazardous waste person and the junk vehicle coordinator. So with Peter leaving, we have to figure out what our next steps are for this. And, we're very thankful for how much has been accomplished and feel really good about the building design, and can use that design at either place. So that's our story right now. Yeah.
Can I ask some questions since I'm new?
Yep.
So I'm assuming this would be a new FTE for this position out there to collect it?
That's right. It wouldn't be a full FTE, but yes.
It's
Whatever.
0.5. And it actually was already in this year's budget, anticipating that when we got the facility started, then we'd begin hiring.
Okay. And then I know overseas countries, specifically China, have stopped accepting waste from the Western world. That just happened like 2 or 3 months ago. So have you built in resiliency with the vendor who's going to offtake our hazardous materials and understand what their cost structures are going to be and what their plans are moving forward? Because there could be significant increases in hazardous material disposal. We're experiencing that ourselves from our thing, just for the bids that we're getting from them. Some of them are 10 times higher than they used to be because they used to just ship the material to China and have them reprocess it. And so that should be something that should be at least thought about and understand with our hazardous material off-taker, so we can understand what's going on there and if there's other ways to divert that for recycle, reuse, and potentially a revenue stream. I know recycling batteries is a big deal now, so recycling the metals out of batteries, there might actually be value in that material now as opposed to other things. So I'd be interested, maybe not this time, but understanding a couple of those things going
Yeah,
forward.
and that's excellent information. Of course, if we did that event, we would also have that same issue that we would have to look at about cost. Do you want to say anything about the people that we have been using and what
Sure.
they've been doing with it?
Yeah.
I'll give Travis the seat. Travis Ross is our water quality specialist, for those of you
Everybody.
who haven't met him.
So traditionally, we've been using a contractor that subcontracts with Clean Harbors, which is a hazardous waste disposal company. We're looking at liquid waste, no batteries or electronics, anything like that. So that waste, the flammable material gets incinerated for energy recovery. Pesticides, strong acids, that sort of thing is going to a regulated landfill in the United States. So those are our two methods of disposal. Waste oil does get recycled, but again, it's staying in the Northwest.
Okay.
And
Thank you.
I think it's good timing as well with the budget coming up to get any impacts into the.
Yeah, that's
your
what I was
budget
thinking
for
of, we were
19.
talking from
Yeah.
the budget, so.
Yeah. Yeah. I wasn't sure if you were done. Or do you have more questions? Rob?
Well, I was just going to ask, so what is the sort of proposed timeline at this point? Because we now haven't had we didn't do hazardous waste collection last year in anticipation of this being built, so like,
Right.
For the public, when is something going to be available?
That is a good question, and we've been asking ourselves that as well. Basically, I'm going to say, just can we get back to you on that? Having an event is not out of the question. We normally hold our events in September, and so it's not impossible for us to hold an event this year. But we need to regroup and figure out what our next steps are, and yeah.
I think we put most building projects out to bid in November, so I would probably suggest, just
Doing that.
what we do, yeah.
That's a
Keep it
good
to two,
goal,
yeah.
because then we won't be up against that February goal.
Like late October, November.
We have the architect, there's a 3-month suspension clause in the contract, so that's engaged at this point or in use. And looking at that other site with more due diligence, we did look at it before, but kind of at 10,000 feet, then went to this site.
Mhm.
So that'll be, I think, the next most important step, so that we know what site we're at and we can look at sewer and water and be ready for bid.
The other nice thing about the other side is that we recently built a building out at the junk vehicle yard, so we do have some of the civil engineering investigative work, which is called something very specific, that you probably know. So Debbie knows.
Geotechnical investigation.
We've had some geotechnical investigations done at the site.
I have to familiarize myself on Deschaux Lane, but will the access for the new space be right off of Deschaux also?
It would not,
Okay, because Deschaux Lane is, part of it's going to get paved this year.
right? Which is exciting. Yeah, it actually would be, I can bring it up. I don't know if I'm taking too long, but.
Doesn't it front 2 streets at Deschaux?
It doesn't, but the access is off of, what's that road that goes,
Pulp Mill Road?
Is it Pulp Mill Road? Yeah.
No, that's further.
I couldn't find a name for that road.
I was thinking for circulation, it might come in on one and out on the other.
We'd have
Vice
to
versa.
change some things in our junk vehicle yard, but the good thing, I mean, that could be a possibility. We are crushing our vehicles this year. We have over 250 cars, so we're crushing them sometime this spring or summer, which will give us the ability, we need to do some grading and stuff in our junk vehicle yard, so that'll give us the ability to, I'm sorry, this is not numbered.
Yeah.
Racetrack. Okay.
Is it?
Well, the folks out in there, that area too are looking to form an RSID to do some pave that section, so.
Oh, that's good.
We could end up with.
Yeah, there's a subdivision just undeveloped, just west
And don't they have
down that
sewer?
road.
Yes, we have sewer.
Sewer and water,
We
which
have
is an
sewer
issue
well.
over here.
Area out there.
Yeah, the sewer just runs right along what I'm talking about, but, yeah.
I mean, we're talking about a lot of concrete and a pole barn for the most part, right?
It's a pretty fancy, not really a pole barn, but it's a,
Lots of concrete.
yeah.
A lot of concrete, yeah.
Yeah, it's
Containment.
good ventilation, but kind of an aluminum building.
Steel building.
Yeah. steel
Pre-engineered
building.
metal, I think is what it is.
If you need grading done, you can also use the college technology, depending on the time of year when you have students.
Oh, good.
If there, isn't there already?
Property info, you
Yeah,
know.
sorry. Is there what?
Isn't there already office space and restroom facilities and stuff like that out at the junk vehicle
Yeah,
yard?
we
Would you
just-
need to build the same facility out there, or would you be able to use some of that
Doghouse, isn't it?
existing?
The building we just put up is a garage with an office and a bathroom.
Mhm.
And it is actually on the Deshaw Lane end, the north end of the property. You'll see in a minute.
But you're right, there is some possibility to look at doing it differently out there, to have more shared spaces.
Maybe cut down
Yep.
on your construction costs and things.
Yeah.
And speaking of geotech, we had a lot of problems with the soils and compaction out at that area, so that's,
Yep.
that we didn't expect.
Yeah, it's really, it's clay. So this is our beautiful little junk vehicle yard, that's the old movie theater. This right here is Deshaw, and so it's this road here, is that what's called Racetrack? I
Yeah.
can't see what
Yeah.
this thing. So this was the road, I couldn't remember the name of, what it comes off of, but this road right here really does not exist. It's just a two-track road, but sewer runs right down this road. We have a well here, so they would share the well, but we're talking about this property here that's never been developed. So they would come in this way, but there's an industrial subdivision right here that the owner of would like to potentially develop, and it's hard to sell those lots with no access, and there's no access built right now. So it's a platted road, right? Is it a platted county road?
Yep.
Okay. So Travis did some initial talking.
So I have an odd costing question.
Well, you can show if you put on the right layer, you can show the county right away.
So do none of the local recyclers buy cars anymore? I've sold junk cars to like,
Pacific.
so
Yeah.
my only question, I guess, is there's a junk vehicle facility with junk vehicles. Is there any economic value to just selling those vehicles off to a recycler and going from that, even if they took it?
The state gets it,
This,
sorry.
we do, the state gets
Oh.
the revenue.
What?
Yeah.
Okay.
Well, but it's also paid for, I mean, basically, all counties have a junk vehicle program because the price of steel goes up and down. And we will take it for free. And so when the price of steel is down, I mean, we'll tow it away for free. When the price of steel is down, and it's not worth towing it to one of the recyclers, we will do it. And it does get recycled.
I was just wondering if there was enough room, if the partnership could be organized with another recycling company on that one lot to where you didn't even need to build purchase new land. What if you could use part of this facility for it?
Oh, I don't think we need to purchase new land. We
Well, I
have the
meant,
land.
excuse me, new construction or whatever.
Oh.
You know, is there some way to be able to utilize this property in the same way? Because it already has access, it already has sewer hookup, it already has power. If that full space isn't necessary based on partnerships for the junk cars, and if they need to be stored that long, I mean, I don't know how much space we need for the hazardous material recycling location, or if you even want just anybody rolling up to this junk vehicle yard, that may be an issue as well too, from that aspect. But there could be some opportunities there for some significant cost savings.
We did look initially at putting it in the developed part of the yard, and the size of the building, so you don't see the junk vehicle building here on this layer, but the size of that building and the location that that building was put in, and the need for the other location, and the need for us to separate the public from the junk vehicle yard, all made it, that was one of the reasons why we decided not to look at it. But when it became evident that the cost of sewer and water service was really gonna be a wash with the cost of creating a new roadway, it made sense for us to look at this site again.
Okay, cool.
So, but it is good for us to remember to take a step back and to look at the whole big picture of what's already out there and what we would need and what we wouldn't need. So. And I don't know, Ellen, if you wanted me to, you said something about the budget.
Oh, I just wanted
quarterly
to
budget.
mention, because we are doing the mid-year budget review, I could just jump right into that now. And
Yeah.
the money that has already been donated for this facility from Phillips 66 and Republic, it was actually $150,000. We've spent down about $6,000 of that in prep so far. That is sitting in cash reserve. We have another $95,000 pledged. Most of that's from the city wastewater treatment plant. And a piece of that is from Republic. And then we have in our cash reserve another $82,000, which would give us a maximum, which would have to include sewer, whatever else for the site, and the actual construction of $321,000. Those numbers hold.
And of that, we spent about 30,000
Yeah.
this year on the architect and consultants, so.
But the .5 position is already fit in the budget, even though we haven't hired.
And that's separate from all the money that Ellen was just
Mhm.
talking about.
That's the operational aspect of it. So.
And our vision is that that .5 person could also do more than just, not just, but more than taking in the waste and sorting the waste, but also could be out in the community, helping businesses and individuals with large quantities figure out how to deal with their waste. So that's part of what our hope is for that position. All right. And everything else, just FYI, on the water quality budget looks to be on track.
Right, everything
so
else, there's nothing
No surprises.
remarkable going on with operations.
Is there a trend assessment on what's commonly donated during hazardous waste days, like an accumulation? Can I see that data at some point?
Absolutely.
Yeah.
We could easily get that for you. That's something that we track, so.
Mhm.
Awesome.
Yep.
And you might just look for the email, because it was sent to us after the last collection.
Household collection.
Yeah, it was, because I think we asked for data on the pounds and gallons.
That would have been
and-
2016 then, since we didn't collect in 2017?
Yeah.
Okay.
It also, is it already in the, anyhow, we'll get.
We'll get that.
Awesome.
It's either in the
Present that.
strategic plan or the performance measures, I can't remember which one.
Yeah, we were just tracking certain types because we were trying to move
Mhm.
towards certain types, away from other types. So I'm not sure which, but we'll get that.
Because like the latex now, we suggest that if you have
Yeah, we won't
good
take it.
latex paint, you take it to
Yeah.
home resource to get reused.
But it's,
Yeah, and Home Resource is willing to expand what they take. And so Peter's started conversations with them about, what would make sense for them to take so that we could do some of that direct reuse of other chemicals that fertilizers, we get fertilizers.
I was thinking fertilizers and pesticides, there might be some opportunity there for,
Mhm.
if nothing else, working with other potential donors like a Lowe's or Home Depot or whatever. If it's like, hey, this ends up in the community, it needs to be collected. We're building this facility so it can be handled. Are you guys interested in participating or helping the community?
Yeah. We might need some more money, so that's a good thing.
That's what I was thinking of.
Always give me some money, exactly. All right, thank you.
Thanks, Shannon. Next up on the agenda is the Water Quality Advisory Council update from Travis.
Okay, So the advisory council met on Tuesday and went through some very thick materials regarding the Smurfit Stone site. So EPA came to town last month and presented on the human health risk assessment for OU2 and OU3. So those are operation units 2 and 3, as well as the baseline ecological risk assessment for that site. OU2 is the industrial core, where the buildings, the paper buildings, and primary industrial operations were. OU3 is the sludge ponds, the wastewater ponds, really the largest chunk of the area. So as part of the risk assessment, what they do is they compile all of the data gathered so far on the site and plug it into a model and look at the risk of exposure to humans and animals to determine what the excess cancer and non-cancer risks are for humans, and then detriment to the ecological population. So in reviewing their models, one big thing that comes out is the 130 acres of landfills or dumps, if you will, and sludge ponds are not addressed. There's very little data. It's the conceptual model does not include the fact that these materials are most likely in groundwater, and there's a possibility of erosion and large flood. So that's probably the biggest inadequacy of these plans. When they went through, I guess we could look at it unit by unit, but in OU2, the industrial area, they identified the contaminants of potential concern in surface soils to be dioxins and PCBs. When they looked at the exposure model, however, they found that those contaminants were not likely to cause cancer. The problem we see with the model is that a lot of that data is based on 20-acre composite sampling. So if you look at the chance that a residential or a resident in that grid were to be exposed to enough PCBs to cause cancer, you're looking at 20 different samples over a 20-acre grid. Average that together and you get a number. That does not account for how people actually live. We don't access 20 acres of soil evenly in our neighborhood. So that's a flaw, we believe. As you get into the OU3 area, the sludge ponds and landfills, those are still 20-acre grids, the 20-point composites, and then the floodplain itself is increased to 100 acres. So you're looking at 30 samples over 100 acres and average that. So the data is, we believe it's not adequate. It doesn't protect human health. And though the models may show that there's not substantial risk, still it depends on what kind of samples you're taking. The other concern is there's a number of contaminants in groundwater, and those contaminant models also average the concentrations in the whole site of groundwater. So if you've got a high manganese over here, a low manganese over here, high dioxins over here, but low over there, it all gets averaged out. But we know that's not how individual wells or drinking water in individual wells are consumed. So an inadequacy there as well. Really, the two big things that come to mind are the dumps are not adequately addressed. We don't have a profile of the depth and the types of material. We're looking at one soil boring per sludge pond and dump. It's just not adequate. And so we have no quantification of the types of materials in those dumps and the volumes. That's a big one. The other really question, actually it's a rhetorical question, is it appropriate to do a risk assessment when we don't have a full characterization of the site? And I think the answer is no. It's too early to start talking about risk when we don't know what's out there. So The council is working on drafting some comments. The district will be drafting some comments. We'll be meeting hopefully with the commissioners in the next couple weeks to see if they have some comments. Those are all due by April 2nd. It's a lot of information. The community advisory group in Frenchtown is very engaged right now in drafting their own comments. So this is kind of forefront in our issues right now.
Travis, did you guys have anything that was going to come back to this board for a letter for this board? And the timing's not great, but I mean, we could take it up on email if you were wanting.
Yeah, that would be great. I don't know what the protocols are for that.
What's the due date?
April 2nd.
You'd have to have a electronic meeting, so you have to have a meeting in real time, even if you're not in the same space. So that's not impossible if you had a draft. We usually don't do that without the Water Quality District weighing in, but it sounds like the Water Quality District was just Tuesday night working on this.
Yep.
Then you'd have to get a draft, post an agenda, get a draft for these folks, and then we just set up a public meeting with adequate notice. We open the phone line in a room, so members of the public could come and be in the same room and listen to the meeting in real time. So you can do that, and I'm sorry that the timing isn't
Yeah, we don't
lining
control
up
that.
to have gotten that today. But I want to emphasize, and of course I'm going back to the early years of when we pushed for different cleanups, and we always push harder for the assessment. You have to. And I just have this sense that, well, it's more than a sense. I just have the sense that EPA is not really clear they're in Missoula yet on this, because I don't know where that level of sampling would fly, but it sure wouldn't here.
Yeah.
So I think it's very important, and I won't be here, but we have done it before, and I think that we could do an electronic if you wanted to. What you
You know, you
can't
have to
do
do the
is
act-
just talk on email and say, I'm okay with this.
Right.
That's not,
And I'd be happy to help shepherd that process if you wanted a meeting electronically, if you're gone.
So I guess, Travis, just keep, Ellen apprised of where it is, or whoever the acting health officer is going to be, and we can, we just are going to have it about 8 to 10 days before, so we can do the notice and then gather up whoever's available on the.
you only
conference
need,
call.
you don't really need 8 to 10 days. We try to give you 8 to 10 days, but there's not a legal requirement, just reasonable
notice?
notice.
Notice is just reasonable.
Mhm.
Okay. So
Yeah,
we could.
the rule
push
of
it
thumb
about
is,
2 days.
rule of thumb is 2 days unless
Yeah.
it's an emergency.
Goodness.
Mhm.
Okay.
And then the go-to meeting, I think we can plug in a public call line. We used that when I was in London, and
Yep.
that worked very well. And I think we can review the document, we can look through stuff, and I think everyone has a smartphone these days, so it's really easy to get the app set up and organized from that aspect. And if someone
We
here.
could use the GoToMeeting connection. I can show you that, and,
Okay.
But if
yeah.
we're just reviewing the letter, the data.
Yeah,
we
you
might
may not need to,
that.
but,
No.
but I would appreciate that you doing that, because I think this push really needs to be emphasized. And one of the things we don't seem to have that we had when we were looking at other sites in those earlier phases is the kind of media interest. We have some, but it doesn't feel the same in terms of getting the public
Although I've
notified.
received calls from, I think which one, Senator Dane's office more than once about what's going on in Frenchtown, so there seems to be a little interest from them, but I think they're picking up.
Yeah.
So.
Okay.
We'll
I
give
was
it a
at
go
that
then?
meeting- I was at that meeting in Frenchtown, and the audience was a little bit more than surprised on multiple points. And I personally felt like the EPA was kind of blowing it off. It was, especially when they announced toward the end of the meeting that, oh, by the way, the owner has asked us to deed restrict this, where we can't drill wells on. Everybody's like, wait a minute. And then they didn't say this in the meeting. Afterwards, I went and talked to the officer, and I said, is it still going to be cleaned up as though it were going to be drilled for residential? He's like, oh yeah, absolutely. They have to clean it up to those standards, but they didn't say that in the meeting, and that bothered me. The other officer, the female officer, kind of said, we're going to hold them to the highest standards, and it felt very strange, and it felt very rushed.
I agree. And when they get to the cleanup action level, right now they're just looking at risk, but then they'll take this to the negotiating table and probably bring in that deed restriction. And so what that means, we don't know.
Yeah, we fought
We
deed
don't feel
restrictions
like,
before.
feel that property should be held hostage in perpetuity to
That,
cleanup standards.
yeah. Deed restriction was tried on White Pine and Sash too.
Right.
Yeah, it felt like a tactic.
Yeah, it was active.
Definitely.
Absolutely.
Thanks, Travis.
Thank you.
Next up, public comments on items not on the agenda. Seeing none, any board or staff comments on items not on the agenda?
I would just say, one, Commissioner Dave Strohmeyer is in Washington DC today. He was asked to be part of a panel testifying in front of the U.S. House Energy and Natural Resource Committee on mine reclamation. And he's either being followed or preceded by Mr. Zinke, so that should make it interesting. So of course, he's emphasizing a lot of the work that we've done in the 9 Mile area, which is where most of our mining is done. And of course, the Milltown Dam was impacted by mines, so he was asked to be part of that panel, so that was very nice. I'm sure he did a great job.
Good. Anyone else? Seeing none, we'll close the Water Quality District Board meeting and open as the Board of Health. First up is minutes, which we don't have, right, Julie?
Correct.
Okay, so on to item 2. So we have our journal report, and Pam is going to give a travel.
Is it a journey report?
This is my travel, yes, this is
Yay.
a travel log.
This is always fun.
The drive.
Somebody stole the mouse.
While we're getting set up, do we have a volunteer for April? Our meeting will be on the 19th, it looks like. April 19th. Anyone? Not sure.
Do we have an agenda we want to discuss or something we're interested in?
Do
Or
whatever you want.
No, it's.
you should know better than saying that to me, right? You can do whatever you want. I
No,
can bring
you
up something
can't.
ridiculous.
No, you can't.
No, we've had ridiculous.
It has to
No
have
robots.
at least
Yeah.
a tenuous link to public health, and what doesn't?
We had the.
He has a very interesting topic that frightens me.
Yeah.
Let's
No.
see.
Nicaragua, it should say Nicaragua Public Health System.
2 up, second one down. Yeah? Yep.
All right.
We've had the making of sanitary pads in India, so.
You can do your travel log, you just got back.
I just got back from
No.
Latin America too.
That'd be great.
Let me think about that, but I'll do it for
Okay.
April.
Just
Yeah.
don't do that one yet.
Yeah, I'll wait for that one.
Wait a little bit.
He's
I
not
got
on
it.
probation.
Yeah.
There's no probationary period.
There's no probationary period.
It's quite ridiculous, but realistic, so.
Well, you've taken Garen's
Sounds
place, so
exciting.
I'd say go for it.
That's true.
Okay.
Just don't blow everything up.
Oh,
Don't worry, because I can. So, Missoula College took a group of students to Nicaragua over break to get kind of a global nursing experience. And this is Nicaragua in Central America. It's the largest country in Central America. It's about the size of Louisiana. There's 5.7 million people in it. It is the second poorest country in the Western Hemisphere, so it has a lot of issues because of that, that we were lucky enough to be able to explore. So one of the things that we looked at as we took the students was what the system was going to be like when we got there. And they actually have an organized public health system. It was put into place after the Civil War with the Contras and Sandinistas and really started to develop about 1990. Up until that point, 70% plus of the country had no health coverage at all. But since that time, they have developed a network of public health services. And it is run by the Ministry of Health and currently now covers at least 70% of the population. They also have the Nicaraguan Social Security Institute, which covers the government workers, and that is about 10% of the population. And then there's a small percentage of the population that pays for private health care. And those those are like expats like us and people that have more money to be able to do that. The Ministry of Health is responsible for both the regulation and the provision of the healthcare services, and it's broken up into two sections. So the Central compiles the regulations, and then the provision of the services is implemented through a variety of health facilities, and it is controlled by the Cialis, which is a kind of a comprehensive healthcare system. They have the system broken up into administrative, which is the Central that does this, and then the health services. And the health services have the national reference hospitals, the departmental hospitals, and those are mainly in Nicaragua. So there are 32 public hospitals, and mostly they're in Nicaragua, although there are some in Leon and a few in one, I think, in Granada, which are also larger cities in Nicaragua. The departmental hospitals are specialty hospitals, so they're like orthopedics and oncology and those kinds of things. And again, those are mainly in Nicaragua, in Managua. And then it breaks out into health centers, and the health centers are spread out through the country, not evenly, but they are spread out through the country. And so they have beds and are kind of, I don't know, like 24-hour stay sort of situations. They're not for surgery and that kind of thing. And then those centers have underneath them what they call health posts, and those are what we went to, were the health posts. And so the area that we were in has 4 health posts, and we went to 3 of those. And they are in these really tiny little towns. And out of the health posts, then, there are community-based services that are run by nurses. So the health centers are bigger, and they are in the larger towns, so like Granada and Leon, and they're kind of full service. So they've got pharmacies, they've got labs, they do immunizations, mental health, they offer some dentistry, and most of those centers are located in the Pacific and Central regions of the country. The Caribbean has the lowest population and also has the lowest doctor and health care ratio. On average, a health center with inpatient capabilities will serve about 170,000 people per center, and the ones without beds serve about 36,000 people. So they cover a large number of people. These are the health posts, and these are where we went. And so this is the waiting room of the one that was in El Tránsito, which is where we stayed. We joined up with them and did things like the health screenings and malaria screens and things like that. This is the waiting room, and it was broken up into two rooms. Back here is the doctor's room, and back here is the nurse's room. The charts are kept, they're obviously paper charts, and they're kept in kind of a public area that the patients can actually go and get their own chart and take them with them to the doctor when they walk in to see the doctor. And this is just an example of what the vaccination records look like with everybody there. These posts are staffed by nurses primarily. They do in some cases have a doctor. Doctors are not really, they tend to go more into specialties. So 50-some% of the doctors in the country are specialists because they get paid a whole lot more. To kind of counter that tendency, the government has required doctors to do a 3-year residency in a general medicine situation. And so the doctors rotate through these clinics, and some of them will have it, or posts. So some of them will have a doctor for a day, some of them will have it for longer. This post did not have a doctor. 2 of the other posts that we had a doctor that came on certain days. So So these are mostly nurse-run, and the nurses will do all sorts of care here. They do well child care, so weights and heights and nutritional education and things like that. They give immunizations. They do the pap smears. The nurses do pap smears. They provide prescriptions, so nurses can write prescriptions. So if somebody comes in with hypertension or they need some birth control, the nurses write the prescriptions for those. And so pretty well based nurse kinds of things. They do testing for AIDS and HIV, and there is about one post for every 6,400 inhabitants, and so that means 1 to at the most 2 nurses for that many people as well. So it is there, it just isn't really well covered. Out of this, once a month, these posts, the nurses go on home visits and see people who have been lost to follow-up or are unable to come into the clinics themselves. So a lot of the people that we saw were wheelchair-bound. We saw people who had amputations from diabetes. We saw cerebral palsy kids. It was just kind of a variety of things. We saw somebody who had a PAP that was bad and hadn't come back for 9 months, and a pregnant woman who hadn't come in for regular care, those kinds of things. The students were amazed because they just asked them questions and didn't really do much as far as evaluation goes. So, the students were like, well, they're sitting in wheelchairs, shouldn't we examine them for, pressure sores and things like that? And the reason they don't is because they have no supplies to be able to dress a pressure sore if they saw it, or an antibiotic to give if they had it. So the ability that they have to really do much with anything that they find is so they don't look, basically. But they do have a connection, and it does build a trust with coming into the clinic if you need it. So with this, there are volunteers that are called brigadistas. Almost everything medical is named after a military type thing in Nicaragua, which was very interesting.
It's
All
like
the
Contra
hospitals
country,
have-
yeah.
they just have kind of been under military rule for so long. So they have volunteers called brigadistas who will go out and do some home visiting as well. There is a network of midwives that are not certified midwives, they're just midwives. They are trying to cut back on that because they would like them to go to the pregnancy centers that they're beginning to develop, which is, I think, based on the Cuba system. But the midwives still are where people go, and it's very cheap to have a baby with a midwife. It costs about $20. And so people can afford to do that rather than to travel to a pregnancy center, and so they tend to do that. They also, in one of the towns that we were in, had a doctor who was inappropriately touching patients. And so the women in town did not want to go to the doctor ever and would go to the midwife. And so we had gone to talk to her about stopping, and she said, what am I supposed to do, turn them away? They're not going to go to the doctor. So, kind of a quandary of kinds of things. And then they have volunteers who will give talks on things like STDs and all of that kind of stuff. But it's a very loose network, and we never saw anybody who actually volunteered in the week that we were there, and they didn't have a list of volunteers or anything. So I think the numbers are maybe not reflective of what really happens. The brigadistas do a lot of things. They do home visits, similar to what we did in areas where there are no nurses. They'll identify, report deaths, and they will report communicable diseases that might be identified as well. They try to get people in and organize immunization days and that kind of stuff, and then they will do some of the things that nurses do as far as weigh children and that kind of stuff. But we did have nurses at the clinics that we were at, so that was good. So this is the room where they do PAPs. Again, students were really, supplies are really rare. So there is a piece of paper on this table, but it served every woman that came for PAP that day. It was never changed. There are no gloves, so PAPs were done without gloves. And, there just aren't supplies for those kinds of things. And this is somebody getting birth control, and this is somebody with a child for a well child check. They do have education on fetal development and things like that to help women with nutrition and things during pregnancy as well.
They're doing PAPs, where are they sending them?
So they send them to the central laboratories at the health centers. So there are labs at the health centers, so they have to be sent out. So they don't get them in any kind of a timely fashion back. And then follow-up is really difficult. So cervical cancer is the leading cancer death in Nicaragua because 33% of women have never had a PAP in their lives. And the ones that are, that do get their PAPs don't follow up, so they don't, and there's no place to do a colposcopy except to go into Managua or one of the bigger cities to get it done. So it's a very difficult follow through with an abnormal PAP.
It's so fascinating because Costa Rica, which is next door, has a better healthcare system and universal healthcare and is ranked higher than the United States.
I know.
It's literally they share a border.
One thing that you have to look at, though, is the history of Nicaragua and how it has been. So in the 1890s, they had an American president, an American citizen as president. In 1913, the United States militarily took over the country and was in that country until 1933, at which time we left. But then the Sandinista Contra War, and we contributed to that, and that pretty much decimated the country. And so they're very, very poor because of the military issues that have gone on in that country and the graft and corruption that has gone on otherwise. So,
Well, now they're heavily under Russian influence, and I think they
Yeah,
kicked out our own diplomats not too long ago. So,
and that's, well, there's lots of stuff.
Lots of
There's-
politics, yeah.
The history with the United States is a very complicated one, and we tried to undermine the government, and now that government is back in power, and so there's no. It's logical that they would not be happy to have us be involved. So basically, when we look at all of this, there's one physician per 1,000 inhabitants. And the lowest coverage, obviously, is in rural areas. So Managua, bigger cities have great coverage, but the rural areas do not. And 52% of the doctors are specialized, so they don't do public health. This is a picture of the two nurses that we worked with in one of the clinics. And the place that we stayed in El Transito actually sent a woman to nursing school with the condition that her repayment would be to come back to the community to work as a nurse there because there were no nurses. So nurses are in great demand. There are about 3.4 registered nurses per 100 or per 10,000 people. So not a lot. They'd have two different kinds of nurses, registered nurses and auxiliary nurses. The registered nurses do a 5-year education, and the auxiliary nurses do a 2-year education. So kind of set up along the models, I think, of our PSN and AD programs. The distribution of health workers are that 65% of them are in the Pacific Coast region, so Managua basically, 16 in the central, 10% in the northern, and 9% along the Caribbean. So again, Managua gets the gist of all of it. These are other clinics that we were at. This is San Lorenzo. This is a woman who, she's cleaning speculums, and she has no running water, so this is water that is carried in that is not very clean. So she cleans that off, they go in, they wrap them, and they did have an autoclave, so they were at least autoclaved, which was more than a couple of the other clinics that we went to. They don't make good wages, so a registered nurse will make $210 a month, an auxiliary nurse $150. A general practitioner makes $544 a month, so they do not gravitate to those fields because of the salary. But they're trying to recruit people, and I don't know how that's going to happen if they don't change what's going on. So when we were looking at the clinics, 35% of the facilities don't have access to electricity at all. 45% don't have water. Those that do have electricity get it for 4 or less hours a day. So they really are limited in the hours that they can be open and the kinds of things that they can have to preserve, for instance, immunizations and things like that. Waste management is another huge area that's an issue in the country. 35% of the facilities don't have sewage or sanitation at all. 70% of the health units use an incinerator. This is the sharps container for one of the clinics that we were at. They all use boxes, and then those get incinerated. There's no place else to put them. So garbage is a huge issue across the country. 70% of people, there isn't any garbage pickup or anything for 70% of the people. So again, Managua has it, but not the rural areas. And so 68% of the health facilities don't have any sterilization system at all. That was the autoclave for the PAPs there, for the speculants that we got to luckily see. Medication is another issue that happens. So this is a really fancy container for medicine that they had at one of the clinics. The one in El Transito, where we spent most of our time, was just a board and just a board frame basically that was open, and the ceiling tiles were not there, and dirt fell into it, and there were feces of mice or rats or something on the shelves as well. So sanitation is not good. This gentleman had seen the doctor the day before, was told that he needed medication, given a prescription, so he went to the pharmacy, he got this, and he brought it back. Nobody knew what it was, nobody knew how long it should run or what it was for, and so they just sat him down and put it up, and we hoped that it was the right medicine because nobody knew what it was. So those are big things. When somebody comes in with something like hypertension, they're diagnosed, they get 10 days worth of medication and a prescription, and then it's their responsibility to buy the medication. In the towns that we were in, there's no pharmacy, so they have to travel to do that. So that is a barrier to access for sure. And then money is another thing. And even though it's inexpensive in our eyes, it's a lot of money for them to be able to buy. So a lot of people don't follow through with following with their medications at all. Chronic diseases are getting to be a big thing there. So because of the more ready access to processed foods, they are now getting to have all of the same diseases that we have. So chronic diseases like type 2 diabetes, obesity, hypertension are becoming more prevalent. The country, 55%, almost 56% is classified as overweight, 22.2 are classified as obese. So not much different than the United States, but it's for a third world country, that's a lot. 41% of the population has hypertension. So communicable diseases are a big thing. Tuberculosis used to be one of the biggest things that had a high death rate, but now because the public health program has been instituted, that rate is dropping remarkably. There still is a lot of stigma attached to tuberculosis, and people find problems with employment and stuff like that. There is an HIV, sexually transmitted infection problem there. They don't use a lot of condoms, and there's a very early first age of sexual intercourse, so that is an issue. They have just diagnosed a case of HIV at the clinic that we were at, and if you go into if you're a woman and you go in to get birth control, you have to prove that you're on your period, and that isn't just showing somebody a bloody pad. They actually do a finger probe to see that you are bleeding. They don't have gloves, and so there's a huge risk for transmission of these sexually transmitted infections as well. Mosquito-transmitted diseases are another big thing. Malaria was historically a major problem, but since 1990 has dropped again because of the malaria screening. It's very vigorous malaria screening and treatment that they have done because of the public health system. They have a warning for pregnant women not to travel because of the Zika, and the chikungunya was diagnosed first in 2014, and within the first 7 months after it was diagnosed, 2.9% of children between the ages of 2 and 14 were diagnosed with it. So that is a big issue that is, and I don't have firmer numbers than that, but big thing. Cervical cancer is the leading cancer and the second leading cause of morbidity in Latin America in general. It's second only to Haiti in North Nicaragua. Patient follow-up is the issue with that. And then violence against women is huge. 52% of women of childbearing age have been identified as being a victim of intimate partner violence. And there really is not much that I could see going on with that at this point.
Was HPV vaccination available?
Not readily available. I think it's available in Managua, but it was not at the clinics. It was all the normal childhood stuff, but the HPV stuff was not. So they have a very high fertility rate, and the women in Nicaragua typically have their babies by age 20, but they it's a Catholic country, but unlike the other Central American countries, they do accept birth control, and so it is actually it was really interesting. If you had more than 2 kids, people were making fun of them. Their peers were making fun of them. So so birth control is encouraged and used, but not until you've had your babies. So all in all, I think that things are changing for their healthcare system, but it's good if you live in Managua and if you have money, but if you live in a rural area, which is the majority of the country, it's really, really poor. So we're hoping to go back and continue our relationship with the clinics that we started, and then to connect with some of the other volunteer groups that are already set up in El Transito to do more public health, which would be garbage and water kinds of situations. So that was it.
That was so interesting.
That was the trip. Plus, we got to surf. So that was not all bad.
What an eye-opener for the students, huh?
Yeah, but most of them had not ever been out of the country, let alone been to a country as poor as that, let alone someplace that didn't speak English. And so the whole first part of the week was very unsettling. By the end of the week, it was like, this is the best experience I've ever had in my life, and I think we can do this, and we should do this, and we should do that. And so it was really, it was very interesting, but we did have a little bit of anxiety in the beginning.
I always tell everyone Latin America, Africa, or Haiti will change your entire worldview on everything if you visit those areas.
Yeah, it's pretty incredible. So it was interesting to see. I do think that they're trying to. I've been to Cuba, and I think they're starting to try to model their system on the Cuban model. But they've got a long, long way to go because Cuba's is really good. But I think that's the model that they're using here. So.
Great, thank you.
Mm-hmm.
Great report. Next up on the agenda, I want to introduce Colleen Morris.
Yes, we had one brief month where we were with the full management team before Peter left. So we are very pleased that Colleen Morris has stepped up to be the manager of our outpatient clinic immunizations, travel immunizations. And Sarah, did you want to add anything or just have?
Well, I'm super excited. Colleen was one of our home visitors, so this was an internal move. We had, I think, 3 or 4 failed recruitments for this management position, and so there's a significant period of time with that being vacant, and when Colleen finally decided to apply in December, we're super excited and to make it internal is even more heartwarming. So like to be able to see people move up. So she did nurse family partnership home visiting, was our child care resources nurse who did the daycare immunization reviews. So she's got a lot of great
Infectious
experience.
disease.
Yep,
Yeah,
did
for a while.
infectious disease before. You worked in the clinic before, so you've kind of had your fingers in
Yes.
everything. So I think you're a great addition to the team, and we've got a steep learning curve, but we're going to get there, and super excited to have you.
Thank you. I'm excited to be here.
Say a word and we'll ask you each to introduce yourself if you would. So,
I'm Pat Boyd.
have a seat. Have a seat.
Julie Armstrong, with City Council, welcome.
Hi, nice to meet you.
Jane Curtis, Commissioner, we just met yesterday, or the day before,
Rob
probably.
Stanger, hi.
Hi.
I'm Debbie Johnston.
James Stevens.
Anna Conley?
Hi.
Do you have anything you want to briefly say about your new position?
Oh gosh, I don't know. I'm just really excited to be part of the team, and just kind of have jumped right in and do have a lot to learn, but even in, I think, a month that I've really been in the position, just learning so much and finding it really interesting to be part of all these sorts of things. Just getting to know more about how the county works and operates, and so thank you.
Welcome.
Welcome. Yeah.
We'll have you back.
I have a comment that ties into last time when we were talking about advertising the immunization stuff. I have numerous slots left on the Chamber of Commerce, the email blast left that we haven't used, and I'm willing to donate one or multiple ones of those to the County Board of Health to try to get some more immunization stuff out there. So
Thank you.
if we can figure out a little ad or whatever, I can coordinate you with our team there, but we can start putting some stuff out to the Chamber of
Thank you.
Commerce. And I think once it gets out there, we can kind of
Yeah.
encourage some other business groups to start putting that information out.
Great. Thank you. Great. Okay, we'll be in touch.
Thank you.
Thank you. Welcome.
Coming up.
Ellen, you're up again for the update on the effect of the Medicaid rule change.
Yeah, that really leads into the budget reviews, but, so let me try to keep these straight. Yeah, I think I'll just come over there and see if I can, all these issues are kind of interwoven.
Do you
here.
want to switch and do Heidi's update
I'll
first?
go ahead and, most of the major budget really focuses on this topic, so I'll go ahead and dive into it.
Okay.
And then we'll come back and the areas that don't appear to be having any major changes,
yeah,
we can
that's
touch
the way
on
it
and
is.
answer
Okay.
questions.
Perfect.
I think that'd be the best use of your time.
I was reading the agenda wrong.
So I think it should be this one. Oh, we got this one.
Yeah.
No, that's the one that's got the wrong cover on it. Isn't that weird how it did that? It's goofy. Very strange. Where's the show thing? Start from beginning slideshow. No idea.
Down here, if you were, it's fine.
Oh,
See
yeah,
the little-
I usually use it up here, that one.
Go
No,
over
see,
and
there.
One more.
One more.
That'll
I guess it worked.
Yeah, that one. It's full screen.
So you won't have notes or anything?
I don't need notes. I only use notes when I'm trying not to say something. So you've heard a lot of the drama, the real drama, about the state cuts at various levels in the community. And the Medicaid rule that we testified on in February was released at the end of February and became effective March 1. And it affects this slice of the pie. So let me back up and tell you about what this pie represents, and then we'll do a comparative look of before and after. So if you look at our MCH, stands for Maternal Child Health Home Visiting, which is the major focus of our health services division. And I pulled out just those programs, contracts, Medicaid, and local tax support of city, county that supports those services somehow related to the home visiting aspect of what we do. So this doesn't include WIC, which of course is very maternal child health oriented. Doesn't include the immunization clinic. So this is our nurses, social workers, and dietitians. So the revenue pie before all this happened, this is our largest chunk of work, really, in the department, if you look at it money-wise, staff-wise. And about half, actually in FY18, it was exactly half of our revenue support is our local tax. So we are really fortunate to have that support. And when you look at it like that and see what's coming, we're even more fortunate. We have a home visiting grant for our asthma nurse. We have what's called the Maternal Child Health Block Grant, which is an ancient piece of block grant. It's when they developed Medicare, they wanted to do something for younger ages, but politically they didn't have the wherewithal they created the MCH block grant. So that's how old it is. Doesn't really change. Important chunk of money. This is the money we've grown over the last 25 years, and that's the Medicaid reimbursement for case management for high-risk children. This is, where did I go? This is for high-risk pregnant women, similar, but once the baby's born, they have to be served here. You can only serve the unborn and the mother here. Then we have our pieces of foster care. So we have some tax money, which you can't see on this two-dimensional diagram, goes into these, in addition to these two state and then local tax-funded foster child health program, which I believe a couple of months ago we sent to you the first level evaluation of that program with some of the good outcomes that we see. So that was piloted in Missoula. This is the seed money for that from the county has a specific fund for basic needs, but they contribute to that outside of their tax money. Where's my little guy going? Oh, there we go. This is safe care. So these all serve maternal child health populations, but with different issues, different eligibility, different approaches. So not everything that we have fits every person. Just like if you go to your doctor, there's a therapy for this, there's a first line for this, there's a second line for that, what works. And so that's kind of the array of what we've built. So some of these are newer funds. So the Safe Care is used for parents who have been referred and filed upon in court by the Department of Family Services for child welfare, abuse and neglect issues. So these have distinguished from the foster program, they've actually been removed from the home. In the orange are the kids that have been filed upon. And so we serve them. And then if they're ordered to that program, the parents do need to go. So we've been having some referral problems on that one to try to realize what we could be realizing there. Our largest evidence-based.
The kids or the parents?
The parents.
Okay, so you're serving the parents in the home.
Yeah,
try
but
to
we're focused
make the
on
environment safe
right.
when the kids
Focused on the
come
kid
back.
and the whole family, but yeah. And then this is our largest evidence-based home visiting program, Nurse Family Partnership, and those of you that are familiar with it know that this has the strongest, double-digit positive outcomes and the longest-term positive outcomes for moms and babies that were served on this. So what we lost is, focus here, I should have lined these up so they're in order, but that was late. So here we don't see changes in our Nurse Family Partnership or our asthma control state funds. I took taxes out of this, it made the graphic really silly. Safe Care, I think I need a pointer. Here we go. We expect that we will not realize 75% of that revenue. Foster care, last time I met with you, was lost. And I got we made cuts. We didn't cut the whole program out, you might recall. We wanted to keep our original pilot program, and we wanted to keep our top priorities, which are 0 to 5, newborn to 5, brand new placements in foster care, transitions, and then those that are aging out of foster care and are going to be out in the adult world, kind of just like that. So we reverted back to those focus areas. We operated it for 4 months without funding, hoping this various funding would be restored or come through, and I finally bit the bullet. And then last week, got a phone call that said, your money's coming back. So very good, but not enough money because of the overall net loss to go all the way back to where we were. So then we have our Medicaid pregnant women. And then this is a 77% loss. It's huge. Our MCH block grant would be the same. I want to speak a little bit about this Medicaid 77% loss. Again, this is what we've grown. We were in that position if we had more to lose because we had garnered more over the years. What you can't see in any of these diagrams is the leveraging capability of that Medicaid for children with special health needs. First of all, when the state cut their match, they cut, depending, at least $1 up to $2 of federal money. So they didn't just cut $1. They lost their leveraging ability because the state.
Isn't it $3?
Yeah, I think it is 3 on this one, but it changes with each service. So I believe it was 3. Jean, I know that the average loss is closer to 2 if you look at all Medicaid leveraging. So the whole state lost that. What we're showing here is what we've lost. It also leverages support for every single program you're looking at there. So if we're to look at our largest, like Nurse Family Partnership, our largest evidence-based program, which is a 5-county partnership with Billings and Missoula being the sort of the ends of the suspension bridge, the towers on the suspension bridge to make that work. That, we didn't lose any of that money, but we depend on some of the Medicaid money to make ends meet. So for everything there, we have a certain amount of funding that may not keep the program whole. You can say, well, you can scale it down. Well, you can't scale down an evidence-based program that has requirements for fidelity to the model. If it says you do 4 visits by this such and such time, that's what you do. It also, with high-risk pregnant children, the Medicaid piece that's lost, that's kind of our receiving. Anybody can call us, and in fact, DFS is a primary referral source. We can get a call from a school, doctor's office, and say, can you take a look at this kid? You know, you're our local government, you're our health department. And then we can do that and see if they can be followed on that caseload or some evidence-based caseload, as well as referred. So we've lost kind of a receiving, an ability to respond. I don't have a metric for it. And we've lost some leveraging and support for all the other programs. I have numbers for that. I don't know how that it'll affect us until I see more how we go forward. I will tell you that we served 533 unduplicated children and their families on that revenue alone last year. So to lose 77% is. The other aspect of it is, and these are small cuts compared to what you'll see in like the mental health system. However, these are almost 100% primary to secondary preventive activities. So the rules that came through, we would not even be able to serve a mom who had twins at 7 months. That's not eligible.
So
we will find ways to serve them, but that's not eligible.
I know these are home visiting sessions, but is there a way to set up telemedicine to try and capture these people? Because once you've built up trust with those folks, and then you just walk away. Is there a way to try and multiply the efforts through
we do
telemedicine, email, something?
We actually use those methods. And so far, because we have the support we have locally, we haven't had to walk away, but I think we're going to have to see how it unfolds and see when we close a case, how we prioritize, similarly to what we did with foster care. Luckily, we just had a quality improvement project that the professional nurses and social workers themselves designed and completed to try to standardize, be more consistent with that kind of care.
So as the transition comes.
Yeah, I know. So here's how it looks on the pie then. Going into, I'm just going to pretend that we're looking at July 1 right now, even though this is all happening right now. So we are trying to adjust. We have a smaller pie, and I think it's better to show you. You can see that is a reliance on tax, goes from 50% to 57%. But I want to show you the next one because it really shows you the pie is smaller, and I've pulled out the two, the red and the orange, where we lost that $207,000 for a total reduction of 14% of the revenue, counting the tax money for those services. We've been working, this is I have a spreadsheet that's very simple, but we basically sit down and we look at the revenue loss, and they're all lined up on one side, and then we look at what expense reductions we can make. And to date, we have either laid off, transferred, or lost through attrition 3 part-time nurses for 1.95 FTEs. By doing that, you can see that we've come closer to balancing against the 207,000. We've had the foster child health restored. It would have been 267,000. Without that, the loss would have been. This does not yet show, but you will see when I bring the budget to you, the additional costs for next year. If the fringe goes up, and certainly any raises, all those percentage points. So our spreadsheet actually shows that. This is just to show you how we've been working on it. That's where we're at.
Can I ask a question? Are we still in limbo with some of the cuts?
One of the rules, so there's the pregnant women, high-risk pregnant women Medicaid, and the high-risk child. The rules that we were set to petition against back in October, that went into effect before all of this happened, would not have allowed us to see our own clients once they went to partnership, for example, or went to Grant Creek, or went to any comprehensive primary care designated private clinic. So it was a big barrier between home visiting and actual clinical care. We did get that reversed for the Medicaid children rule. It has not been reversed for the pregnant women rule yet, but they're holding us harmless. So we asked, when are you going to do that? And we got, I don't know.
So these are all actual cuts, not any of those gray area cuts that they've said, we've cut these, but we are
No, we
sort
can
of...
still lose more. We can still
Okay.
lose more with the high-risk pregnant women if they don't make that rule change that we did get them to make. Yeah. So that's where we're at. I think, we'll have more by budget time. We actually have done more work. We've been using our quality improvement tools, in fact, to try to figure out what to do next. But these aren't clean cuts. They're all kind of interwoven. And so it's one of those things where you move some, you may not fully realize what you've affected. So we're trying real hard to minimize that.
What is the total number of ballpark FTEs in nurses and home visiting? Like that's 1.2 nurses out of how many?
Well, I should have had that prepared for you, because I extracted this budget from the larger budget.
I know it's in here somewhere.
It
I
is,
could go and look and
definitely,
count,
yeah.
but I couldn't figure out where to go.
We have, yeah, I'm sorry, I might be able to send that to you. I can give you totals, but I can't extract right now and do it. It's a chunk. I mean, we're working really hard to not cut at the professional level again, because that's the service end. So last week, we had a work session on administrative support duties, took all of those apart to see how they could be lined up, but we don't have an outcome from that. Any questions or anything?
Go right into that.
Okay. I'm going to ask you to look at the narrative, which you have in front of you. I can barely read it up there. Most of this narrative covers what I just talked with you about, so I will start at the top, skip that and go on, and then try to answer your questions that you have had from your materials. The biggest cost, and this board approved it, but it actually wasn't in the budget, so we had to amend it in the budget. It appears at the top of your sheet, and we took $382 and some dollars from our cash reserves to pay the 20-year lease on 223 West Alder, and pay that 20 years in advance, saving all of that interest, 20 years of interest. So thank you, Anna and commissioners and board. So you will see a huge divot in the cash going down as expected. The next bullet, should number these, was an unanticipated capital expenditure, but you also did approve it, and it was the portion that we put forward to try to get the air conditioning fixed in time for last summer.
Where's the elevator? Isn't that one of those unexpected
We didn't
expenses?
pay for the elevator when it blew up.
So you said, does the HVAC work now?
Yes.
Okay, you
The-
said
the-
intended, and
Yeah.
then I was like, wait.
Well, the part that didn't work, which was the air cooling for the first floor, was repaired. The HVAC is over 40 years old, and you would have different answers to whether or not it works.
Okay.
But it clearly was not working.
It cools the first floor now.
Yes.
Yeah, okay.
Ish.
Ish.
It
depends
on the
on
day,
us.
yeah. And they got it in time just before last summer, which was very important. So I'm going to go down in health services. From the fourth bullet from the bottom, the immunization clinic is performing on budget, and that's for your regular immunizations. Childhood disease preventable, vaccines, flu, adult immunizations. The travel clinic, however, which includes immunizations, consultation, and antibiotics, depending on where you're traveling, is coming in below, it's underperforming. We expected that to bring in 40,000 cash over revenue, 40,000 net, and we've just had a lot of problems with the electronic health record and that whole system going very slowly. So we've done some workarounds on that. Women, infants, and children with budget is performing right on budget, which is great. Didn't used to, so they're doing a great job with that. Our public health nutrition is performing on budget. Environmental health, the next division, performing on budget. Health promotion is performing on budget with one exception. It's not a new one. They have the DUI prevention program, and those revenues continue to decline. And in fact, they've declined even further than what we projected they would this year. And we're going to be coming in, I'd say easily $20,000 short there. We have been shoring that up with tax money for several years. That is not something that I think should continue, shoring that up with tax money when we're making cuts in other parts of the department
And those are the
that
state
affect very
revenues.
vulnerable people.
Those are the state revenues, and they're probably gonna fall again.
Those are related to reinstatement fees for people that have their license suspended or revoked, and then to get it back, suspended, to get their license back, they have to pay a fee. So that's been on the decline for 5 to 7 years, and it is getting worse. So we'll have to look at that.
For good reasons?
I don't know.
I mean, from the public health perspectives, that mean fewer DUIs, because that would be
From the
good.
crime statistics, I don't believe that's the case for the city, so.
They're not reinstating their license.
We keep looking. We even asked the county auditor to look, as well as the State Department of Justice to look, and transportation. And the only certain thing they can point to is declining DUI convictions. Read today's story about how we have the highest reported heavy alcohol use, and try to put those two together.
I know they settle out on a lot of those things where no one ends up with a DUI, they end up with reckless or driving while impaired over .08, but it's not a DUI, it's something else. So there's lots of negotiations to negotiate people down.
So that's an issue because of where we're at this year. Animal control is performing on the revenue side better than budget, and it's spring, so it's only going to get better because they will be arresting more dogs because they get very springy, and selling more licenses. We have a new capital reserve established for animal control. We haven't actually moved the money into it yet, but you've approved the money being moved into it. And we had a donation from an estate, the name of which I do not know, that can also help with some of the capital needs out there. So they just built a cattery where cats can go in and out. I don't know much about cats except the control aspect.
Awesome word.
Cattery.
Never heard that word. Learn something new every day.
We
ERY.
Water Quality District Fund. We will, in a coming year, not too far out, we will need to be looking at the fees that are the main revenue support for the Water Quality District. They have been raised once since the district was put in place in '92. And once we put this facility up, we will likely be emptying a lot of that reserve cash out. So we'll bring that up in a later year.
Does that have to be voted on then?
It can't be, it's a trigger of protest level. Junk vehicle. You know, one thing to keep in mind if you're a words person or a numbers person, depending if you're looking at the spreadsheet, is these are just snapshots. So, you know, you're looking at what we thought the budget would be, then you're looking at where it was at 6 months. And the money's moving all the time, right? So when you look at the junk vehicle fund, you'll see that it looks like it's got a big negative in there. And at mid-year it did, but we amended in and are getting more money for junk vehicle. So we spent into the reserve knowing that more money's coming in, and that's just the way it moves. And when you take the picture at mid-year, it just kind of depends. Is that money in the frame or did it step out? So the other thing I show on those spreadsheets, and I'm glad to answer questions, but is at the bottom left-hand side, we show what the cash looks like. So if you see a negative in your operations, you should look down and see, oh, but the cash and last year's cash and projected end of year cash is positive. And in all cases but one that I'll get to, you will see that it's positive. So if your snapshot doesn't look good, go to that bottom left-hand part and you'll see. And that's why we can put it in there. The substance abuse prevention funds are new to us because the form just came over this fiscal year. The part that is a mill levy, which is the prevention levy, is performing on budget. But the grants, and if you look at your revenue sheet for the SAP, so you will actually see our projected negative, the bottom line in the lower left-hand corner. You don't want to see that. So I just got done telling you, you should always see a positive there. That's how it looks right now. I don't have enough experience. I believe what I'm being told for people that do have history with this, managing these various grants, that they do a reallocation at the state level at the end of the year, and every year Missoula has gotten a reallocation. And WIC used to live like that. WIC would look negative and then the reallocation would come. So I can't tell you like I can on junk vehicle that I know how much money's coming. So I left that showing as a negative in order to alert you to it, to see if that end of year money actually comes through for us from the state. Your last fund is very inactive. It's the Milltown Historical Fund. It's leftover money from removal of the dam, the power plant. We haven't budgeted to use any of it yet. I can't tell you exactly what the limitations of use are, but they're pretty narrow, and a lot of that restoration and historical work has been done,
Could some
so.
of that money be moved over to Lou Randolph? Because they have some,
I don't believe so. It's
This one was specifically
specific to that super
for
fund.
for the preservation of historical stuff at Milltown Dam.
can it be voted?
It was part of the ARCO settlement.
I thought we talked about using some of it when they developed the trailhead and
I think they
interpretive
could
stuff
use
out
some,
there.
I think they could do some with signs and things like that, but it's been inactive for
Oh, yeah.
many years. So just keep it in front of you so you know that it's there, so if we can find a use for it.
And as the park opens this summer, there could be some opportunity to do some historical
Interpretive
signage
signs,
and stuff.
Okay, any questions, concerns?
So I have a question on the travel clinic stuff. How is the electronic system causing it to be below budget? Like, that's something that's not necessarily jiving with my thought process on
No,
the record
no.
system would cause us to not hit a budget goal.
Yeah,
was-
we expected some loss of productivity when you switch to an electronic health record, but not this. So Sarah knows it intricately.
They basically went from manual billing to electronic billing and adjudicating claims, and it's.
Yeah, in travel clinic, it's not for lack of clients. So the clients are there, it's just our ability to not be able to see them in the same amount of time that we've been in the past. The system, we went live with this new system in June. And so you expect a period of time where your staff adjust and learn how to use that system. And travel clinic is the only immunization piece where it's scheduled appointments, everybody else walks in. So you only have one nurse 3 days a week who has these appointments scheduled, where we adjusted that scheduling matrix to make up for that difference in time learning a new system. The system hasn't been everything that it has been promised or cracked up to be. And so we are making some adjustments within travel clinic to scale back on the use of that system to get back to our original scheduling matrix. So it's all system related, and it has to do with it not being able to function the way that we thought it would function,
Do you have recovery options from the vendor?
unfortunately.
Can we
We've
plan on
been-
recovery options in the future?
If Anna and I have anything to say about it, yeah.
Okay, cool. I learned that the hard way before in the past too. Okay, I just wanted to make sure it wasn't a lack of clients.
Everyone
No,
needs to learn at
but-
once.
Clients are absolutely there. And we have been doing extra days trying to accommodate, to see folks so that they can get in, because we are the only service that provides what we do for travel in this county.
Except the university has
Well,
a travel clinic.
They do have Curry Health, but you have to be a student to access it. Or part of the
faculty,
system.
or a faculty.
Yes.
Yeah, because I think you were the only location to get a yellow fever shot.
Yeah.
Well, Greens
Well,
also is a certified yellow fever site, as is Curry. That's a whole
Yeah.
other discussion because there's a shortage, but it is something that the last 2 previous years has been in.
We have
in the
realized
lab,
the
and
revenue
it's-
previously. Yeah,
I
but
think-
we could lose clients from either end. It's doing better on the walk-in, which is the bulk of our activity, but Sarah in particular is the one who transformed that entire clinic after the Affordable Care Act came in for billing it all and the travel. So she really knows where the knobs are and what works, and this is not working. And it's really topsy-turvy when you think of it. Their system is more designed for scheduling, and this is our only scheduled part of our clinic, and it's where it functions less well.
So when you got it, they were here for however long they were here, helping you establish it. Are they gonna come back?
We brought them back. We brought them back
They
before.
came for 2 on-site
Yeah.
training days, and they were here when we went live for the clinic. We are currently in the process of getting ready to go live with the home visiting section, and they will not be coming back for that training. We're doing our own internal training.
So they're just awful, and they were no good. I mean, basically, they're not helpful.
You
So,
would think the process that we went through with IT ourselves,
right,
checking references, everything,
yeah.
would have not presented these particular problems.
So
But
is
it
there a
did.
way to tweak it or reprogram it?
We're
We've
working
done- yeah.
with the people that are on there and to change things as we're able to. It's not a fast process. A lot of their responses are, well, there have to be other entities that ask for the same request to make it beneficial for them to make a change. So that takes time before they'll make a change for something. So there've been more hurdles than were expected, I think. And it's a daily occurrence that I'm working on processing through those, either in development for homeless visiting based on what I learned with the clinic implementation. With the clinic, it's a lot of tweaking of knobs, as Ellen says, trying to figure out what can we do to continue and improve our efficiencies within what the system has and try to use it to the best of the ability that we're capable of.
Is it a hard install or is it cloud-based?
It's cloud-based.
I don't know, does this sound familiar for electronic health records? I know I can see you nodding over there.
Yeah, it is. You put in change records to get changes made, but
Yeah.
for them to tell you that they're not going to make a change in programming until they get enough clients to make it profitable
Yeah.
for them is kind of some BS.
Yeah. Sarah has incredible pushback,
Yeah, I just,
very good pushback.
Oh, and didn't it kind of get stalled because they started you on a paradigm that wasn't going to work? And then they had to kind of accept that and then overhaul.
Yes. So that took hold. Like, we should have gone live according to our strategic plan back in November or something. So sorry. And so we're aiming for probably May to go live with home visiting. And that'll be a much different rollout and a much different experience for that crew on the good end. So, but our clinic services, we're continuing to, and that's a crash course for Colleen that she's trying to learn. So we're working on a daily basis trying to fix those things.
So sorry.
Yeah.
So as far as the travel clinic goes, have you ever talked to the university about maybe taking over those services for them, which would increase revenue here and decrease output there, which they're looking to do in a lot of ways?
We've always collaborated with them, so we've worked together. If there was something that they didn't have that we do, like we do Japanese encephalitis and rabies vaccines, and they either did or don't, or have one or the other. So they would refer people to us.
We haven't raised the question of like a wholesale.
No.
So,
No,
you
we
know,
haven't.
like, I mean, that may be something.
But maybe if we get our
to consider.
system working. we
Yes,
could-
yeah.
Right, I mean,
I
when
mean, it's certainly.
I was gonna say, use the
When.
word when, and then.
I mean, when we get our
Yes.
system, we wouldn't do it this week.
Yes.
But
You
But,
can
I
always
mean,
go back
but
to
that-
paper.
that's part of what we did.
That may be
Yeah.
something to consolidate those
Yeah.
things so that they're offered and you said the university staff and faculty and
Yeah.
everything still has access, but through here and you guys can expand.
We could streamline it better,
from there.
yeah.
I mean,
I think that's a great suggestion,
Yes.
when we can
Yeah,
get back
you
to
wouldn't wanna do it
realizing
now, but yes.
the productivity that we had realized before.
Yes, yeah, I know travel clinic can be productive, and this
Yeah.
was an unexpected shortfall, and we're gonna get it back to where it was, and that would be an interesting thing to
Right,
explore.
yeah, I think in the time of catching up there.
So I'm a firm believer in zero-based budgeting, and this might not be the forum to do this, but I would like to have a discussion, even if it's just myself and county health staff, on how to make up that budget shortfall for this year and put that into goals and planning for next year as part of the process improvement plan that we've been talking about in your quality improvement. Because then that'll set goals on how to grow it, how we can leverage resources, all that kind of stuff. Because then if we can make up the budget deficit and go back to normal next year, then you have a new bench line to go forward, because now it's not 40,000, it's 60,000.
Right.
And so we can organize some of that goal setting and stuff from there, because that's a lot of what I do.
Like a QI project. We'll talk about it. We're gonna continue to work on implementing the problems we didn't create.
Yeah.
And then we'll focus on those ideas. Thank you.
Thank you very much.
Thanks.
Any
Any other questions on budget? Okay. So now it's our strategic priorities monthly update, and Heidi is here to talk about Goal 8, suicide prevention.
Hi, I'm Heidi Kendall, Suicide Prevention Coordinator. I'm going to show you a really quick slide. My eyes are not that good, is that the right one?
Yeah, that'll.
And now that I know the bottom one's easier, you see that one.
Yeah.
Go to the bottom and the last kind of square looking thing there, and one more.
One more. Next one. Yeah, there you go.
That one's so much easier to see.
Yes, thank you. So this is a quick overview, and I'm happy for you to ask questions or make comments along the way. And I should actually, why did I do that? Best practice would be for me to have the suicide prevention lifeline on every page. So just imagine that at the bottom of each page is the phone number, 1-800-273-8255. So the overall goal for the suicide prevention program is to decrease suicide. So this is the baseline that's in my work plan. I don't know exactly why 2013 was the baseline, but there it is, so that's a benchmark. And these are rates per 100,000. And you can see that the US rate went up during that period. We don't have official data yet for 2017. So 2016 is the year we're using now. The US rate went up, the Montana rate went up. The Missoula County rate actually did not go up, even though the numbers of suicides are increasing, but our population growth has been significant.
Oh, so it's a percent.
Yeah. So breaking down by objectives, when this work plan was written a couple of years ago, it was WMSP, which is the Western Montana Suicide Prevention Initiative. It has been rebranded to be called Project Tomorrow Montana. It's an initiative of the United Way, and United Way and my office are kind of the main drivers of that project, but we have a lot of participants from elected officials, including Jean, to the mayor, school district. There are some banks, the Missoula Federal Credit Union. There are a lot of people who come to the table. We have a leadership meeting from time to time, once or twice a year, and a working group meeting that meets every month. We have really good participation, and we've had to move our meeting room for our working group meetings several times because we keep growing. And we meet now at the Vet Center near the Rose Park. So objective number 1 is to increase our suicide prevention capability by providing training. That is mostly QPR, question, persuade, refer. That particular first task was to train 400 county residents in QPR this year, and we've surpassed that, as you can see. We've trained 588 from the beginning of the fiscal year until now, and some of those groups that we have trained at include the schools, not only MCPS, but also some of the other schools. We just I'm jumping ahead. We just taught 7th and 8th graders at St. Joe's in SOS this morning, which is the kids version. And I will mention that later. Hospitals, churches, University of Montana classes. We've done classes with the Missoulian staff, Veterans Court mentors, CASA volunteers, and the Society of Human Resource Managers, to name some. And I also just want to point out that this is consistent, this objective and action are consistent with the state suicide prevention plan, which is in effect right now. Action 2 is to conduct 3 specialized suicide prevention trainings for 60 frontline personnel. I will say that this is a very valuable skill set to have through this training, but it is expensive. And we offered it last year during September, Suicide Prevention Week in September, but we did not get enough people to let the class go forward to pay the trainers. I learned from that experience. We are going to try to do it again this year, especially in light of the cuts and how badly we need adequately trained people in the community. So we will try to do that again. We need to raise about $5,000 to do that. So I'm thinking that with my new increased budget, thanks to City Council, and with a grant proposal, we will be able to do it if we can find the trainer. So we're plowing ahead with that.
So who do you consider frontline?
When we had this class successfully 2 years ago, there were CSCT people from Western Montana Mental Health. But I think part of offering this class would be making a greater effort to promote it and let people know anybody who works with people who are potentially suicidal could benefit from this. And if we could even get volunteers, like I know that Mikey Connell, who has Joey's Place, which just opened over by the Open Aid Alliance, is interested in having it. NAMI would be a good one to send some volunteers to this kind of training.
How many police officers and sheriff department personnel have QPR training? Or have it even, I mean, certainly they don't at this level.
Right. Well, they have the CIT Academy, which touches on a lot of that, but I don't know the answer to that. I don't know how many are trained.
There may be a way to increase recruitment. I don't know if it's possible, but if you could get this to apply with accredited trainers towards continuing education credits for social workers, there may be a huge opportunity to bring that in so they could do the training and have that apply towards their continuing education credits. And that might get a lot of people involved. So that might be something to think about. Even I was just thinking vet center staff, right? They all have to do continuing education training throughout the year for social work. So that might be a good lineup to offer this training and get it lined up to that. I don't know how easy that is to do at all. So, but
that's a really good point, and we have succeeded with that at Community Medical Center because there was a nurse advocate there who really worked hard to make sure that could happen. I think it's easier with ASSIST, but yeah, we will take that into account and promote it that way too. People do show up for those things for sure.
Because usually they have to keep their licensure, right? You have to do 60 hours or 80 hours or whatever.
Yes, too. Like pay for it and then get reimbursed.
Maybe.
If it's, yeah.
We'll look into all that. Thanks. Action 3, visit 3 Missoula high schools to present SOS, which stands for Signs of Suicide, training to at least 100 youth and 100 school personnel. We have done this and actually handed it over to MCPS for the MCPS schools. That it's part of their suicide prevention training now, starting this school year. So they are training their health and PE teachers to teach SOS themselves, which is a better, it's closer to best practice when they're doing it themselves, because when it's done with fidelity to the model, it's done with a questionnaire about depression, a screening tool, and it's much better for the kids to have that done with their regular teachers who see them every day than having a guest speaker come in and do that with them. So we've trained 234 people in SOS, not including the 40 that we did this morning. Objective number 2 is to provide suicide prevention resources for high-risk targeted groups. These include men between the ages of 35 and 64, Native Americans, veterans, folks like that. One of our actions is to update and distribute 300 stigma reduction brochures, and we do distribute these. We have distributed them at an Osprey game last fall at the very end of the season. The Out of the Darkness Walk, which was in September. The Grief Institute last week. The Trauma Conference at St. Pat's coming up. We're going to do a gun show later this month. And the Veterans suicide awareness and prevention half marathon, which is on May 5th. So those are all places where we will be sharing these materials during this fiscal year. Objective number 2, action 2 is gun locks, and we have distributed over 400 gun locks. I ordered 500 last August, and we have fewer than 100 of them left. But it's kind of complicated because we do get them also from the Sheriff's Department and from the VA, because they also hand out free gun locks. So sometimes I ask them for more of theirs because theirs are a different kind, and it's there's a lot of interconnectedness in the community with gun locks, but people are very interested in them, and we give them out with gun. In our QPR classes, we gave them out at the gun show last year. We'll give them out this year. We give them out at all tabling events. We were at the Grief Institute last week, which was put on by Tamarack Grief Resource Center, and we gave out a lot of them there, which was kind of interesting. A lot of counselors were at that conference. And then we've delivered cases of them to these 3 groups: Missoula Urban Indian Health Center, City Fire, and community groups, including Big Brothers and Big Sisters, and the high schools have asked for them by the case also to give to parents. Objective 3 is to reduce access to lethal means of suicide, including access to firearms and illicit and prescription drugs. This was a new one that was added last year, and I'm kind of still getting the hang of it. Action 1 is to support and promote legislation and policies to reduce access to lethal means. I've been working with NAMI, the National Alliance on Mental Illness, and MCPS. Luckily, I'm on the board of trustees, so I can talk to my fellow trustees about that. Demonstrating safe drug disposal in our QPR classes using the things that Brandy Tyree has acquired with her grant funding, the drug disposal bags and also the storage containers that have the combinations on them. I have also reached out to Carl Roston, who's the state's suicide prevention coordinator, to ask how I can work with him to support and promote legislation and policies at the state level as well. We haven't quite figured that out yet, but it's a good marching order to have, and I'm very happy, and we'll continue to look for opportunities there. And then finally, this is my last page. Action 2 is to inform policymakers and the public about the link between unsafe gun and drug storage and suicide through presentations, news articles, social media posts. Julie and Michelle Cares invited me and my QPR team to speak at Public Safety and Health on April 4th. And we will also do a QPR class that day. We do a lot of social media updates through Project Tomorrow and Susan Hay Patrick and her Facebook on her phone, which is an amazing force of nature. And at events. I do want to say that this is a little bit of a delicate balance that we need to achieve. It's really important as we give our QPR classes to be very neutral on the issue of gun regulation, because we want everybody to listen to us, and so we talk very neutrally about facts, and we show everybody in these classes that 88% of gun deaths in Montana are suicides, and that close to 70% of suicides in Montana are by firearm. So it's just something we all have to pay attention to and be aware of and think about, especially if there's someone in the home who is either a small child or someone who might be suicidal, because that's a quick and easy way to do something impulsive, and if that is made less possible or less likely, there chances of living are much higher. Also, since I'm here, I don't know how widely known it is, but suicide is the 10th leading cause of death in the U.S., and that's something that seems to be a big surprise to people when we talk about it. It's a leading cause of death in the U.S., so. Yep. Thank you.
Thank you.
Can you give me the date and time? I have the date, but I'd like to be present on April 4th to hear how the council
Oh, yeah.
receives it, if you would.
Yes, great.
They better receive it well.
Yeah.
You've put 'em
I
on
wanted to do
notice.
something other than tobacco.
Thanks.
Thanks.
Next up on the agenda is a potential action item, and it's to amend the quarantine and isolation measures policy.
So we really are supposed to revise this, and review it, revise it, and re-adopt it every 5 years. I think we missed by 3 months, but as you can see, the history, this was first adopted as an interim policy in 2003, and it was the first one in the state because the statute the statute for the authorities of local health boards was changed in 2003, Title 50, Chapter 16. And the way the wording was changed, we interpreted it that we should have a policy at the ready, rather than, oh, the board could, do something and we wouldn't have to convene the board. So we wrote it with that idea in mind. It was informed, and it's still informed by a JAMA article, Journal of American Medical Association, about the considerations one should take under consideration before actually using isolation and quarantine. And we also have the latest scientific guidance. I have a couple pictures to show you. I don't want to do the presentation, but I do know that this is new to some board members. I got an interesting and intriguing email from you, James, today, which is why I did bring some pictures to talk a little bit about the source of our guidance and show that to you, but I'll hold off on that until we hear, what some of your thoughts are. I didn't print the email out, but I thought you might want to speak to those.
I didn't really have any negative thoughts on it. I think it's just something that should be considered and considered heavily because most quarantine procedures really do involve suspending someone's civil rights, and there's been very high-profile cases. Specifically, the links I provided were on Ebola quarantine procedures, and that nurse in Maine flagrantly violating that, and there probably should have been force used in that case to stop that activity if you look at the actual rules for New Jersey from that aspect. And so from one of those things, looking at it from a quarantine procedure perspective, I think all of it needs to be treated very specifically, especially because in my email I kind of wrote a thing about how people don't trust law enforcement or doctors or scientists anymore. And so it really has the potential, especially if quarantine needs to be put in place, to cause conflict and armed conflict between citizens and government and law enforcement. And really, it's a delicate situation, and cross-training between health department staff and law enforcement staff is probably going to be vital, and I don't know if it's a component of all of this from that aspect, just because it is kind of where society is. And I think in my email I put the rise of homeopathic medicine being seen as mainstream now and whatever. From that aspect, a lot of people believe this is not necessary, will cure itself, it'll be whatever. And so from that aspect, I think a lot of it needs to be treated very seriously, because with globalization too and climate impacts and change of disease vector locations, we're more and more likely in the future to have to require a quarantine event somewhere like Montana. Which 20 years ago you'd say, no, nothing's ever going to come to Montana. No one's going to fly from Sierra Leone to Montana and risk spreading Ebola. But during the last Ebola outbreak in 2014, there were people that traveled all over the country and ended up having to be either surveilled or quarantined.
Why would you find quarantine any different than evacuation when people were forced to evacuate during the fires?
People won't shoot at you if they're being forced to evacuate from a fire for the most part, because they see a giant roaring column of flame. But if you have someone come back from Africa and they say you and your family can't leave your home, people are much more likely to be like, I'm not sick, you're stupid, you don't know what you're doing, and violate those rules.
So it's an education situation.
It's not an education situation, it's a trust situation. And right now, people do not trust law enforcement, they do not trust doctors, and they do not trust scientists.
So,
I'm kind of harsh, but.
No, I mean, I think you've really hit on a number of ways that quarantine can go wrong. Even if you go through all the thinking steps, it can definitely go wrong. When we were working in the earlier days of public health emergency preparedness, like back around 2002 and 3, and having those connections, or creating those connections really, in some cases for the first time. I remember the police chief Weaver at the time. We did an all-day session and we were going to quarantine against some, I don't know what it was, but we were teaching each other. Law enforcement was teaching us incident command, and we were teaching them communicable disease. And at some point, the chief looked at me and says, "Okay, great, so we have all these people quarantined now. What do I do if they try to escape? Shoot them?" And I said, "Yeah, we got a problem. Got a problem here. We got to think through, you know."
Federal policy used to be yes, but I don't know if it's still.
Right.
Depends
So
on the level of threat.
Yeah.
It kind of encapsulates, wow, you know, what do you do? So I just want to quickly,
Well, and my biggest concern is it's probably the one real chance where your public health staff is likely to be put in a situation in Missoula, Montana, where they might experience armed violence. Or if someone decides to resist a quarantine and someone's going in to take a blood sample, they're going in to help, they're going in to do whatever, it's the one real chance, minus Child Protective Services stuff and what goes on there, where public health staff could really be involved in a conflict where they get exposed to violence. And that's probably something that most of the staff is not ready or trained to do.
so we, on an individual level, sometimes a family or household level, we actually use isolation a lot, I would say almost continuously. Quarantine is a different matter, so I just want to, and I know our doctor and nurse may know this, but I just want to review the terms and the definitions and the guidance that we use for the policy. This is pretty much what you were just talking about, James, is it's all right and good to say we have police power, but we also have a constitution. So anytime you try to restrict, use quarantine in a free country, you're going to have a lot more to consider than like they do in Singapore. In Singapore, they just say, away you go, and we found water where the mosquitoes can live, and you get a ticket, and things happen. And, that doesn't happen in our country, so we have a lot more to balance and a lot more to weigh. So definition of terms, even though they're in here, I really want to get these not just in your head, but our MCAT audience. The distinction between isolation and quarantine. In isolation, you know you've got a sick person who's symptomatic and contagious. Or you're pretty sure you do, and you're waiting for the test to come back. That's isolation. We do that all the time. The ER does that. You go into the ER and you've got a fever and a rash, they're supposed to be isolating you in a certain way. So isolation, we do it all the time. So I'm not saying it's always easy, but isolation, you pretty much know what you're dealing with, and you know that person's contagious. You've seen this picture a million times. Anyone who comes in contact with that person who's being isolated in a way that could spread that particular pathogen is a contact. And the public often thinks, well, a contact is anyone who saw that person, knew that person, touched their briefcase, shared the bathroom. No, it depends on the disease, depends on the circumstance.
And in measles case, that is pretty much what
And
happens.
measles
If you
is-
saw the person, you could get infected.
You don't have to see them.
They just
you
had
can
to-
walk into a room
Touch
12 hours
something.
after that kid was being examined and be exposed to measles.
I'm glad you chose respiratory droplets as your method of exposure for the patient.
Measles is actually aerosolized.
Yeah.
Just like vaping. We were talking about vaping. It's
Keep it
aerosolized.
cheap.
So you don't quarantine someone who's sick, you quarantine someone who's a contact. That's the difference. So the tests for isolation are not that hard, but the tests for quarantine are big.
And it's what people get most upset about.
That's because, yeah, you're not sick, you don't know if you have it, and worse, you're gonna quarantine me like in the old days with somebody else who maybe got exposed, and then maybe I'm getting exposed to them. So the tests for quarantine are huge. Just huge. So I would take what you're saying and I'd say for isolation, not so much, but quarantine, absolutely. This is actually not a good picture for quarantine because that girl actually appears to have the bumps, but I thought it was such a cute picture. So quarantine, as I said, is people have been contacts and you want to keep them in there to make sure they didn't get the disease, that they weren't contagious. That's the distinction. So our incubation period is the period of time from an exposure to the appearance of symptoms, and that you're going to be quarantining people during that incubation period while you're waiting to see if they got the disease and became contagious. And they could be contagious before they actually get symptoms. So it depends on the disease. So there's a lot of guidance these days on different diseases. We do a lot of counting back on the calendar. He was in this classroom 4 days ago. He wasn't there. He served food Friday night. He didn't serve these 3 nights. And we just get on that calendar with our guidance and we count. Sometimes we count, depending on the disease, we're going, well, did they touch something or not touch something? Or were they 3 feet away or not 3 feet away? Or good God, was it measles? It doesn't matter. They walked through them all. So, very disease, situation specific. So keeping those distinctions, I won't go into all this, but it's the period of contagion that we're worried about. It's not always the same as the incubation period, but they usually overlap. That's when you want people isolated, and you want people in the incubation period. Here's the way to do it. If you could do it as a formula, you isolate patients, people who are sick, during the contagion period. You quarantine contacts, people who are not sick but may have been exposed during the incubation period. So that's your mathematical equation, the distinction. You always look at less invasive tools, personal protective equipment, different levels of types of isolation, immunizations, including post-exposure immunization, post-exposure antibiotics, which we use in pertussis, and of course your basic sanitation. So you'll see in the policy, I won't point out where, but it goes through, is there anything less invasive that you can do, then do that. So that's one of the tests we look at. The article that gives us the best guidance, and it's really for large-scale quarantine, but it is the best guidance that's still out there. It's useful for even small-scale or individual, and they have 3 tests. And if you look, as I go through these 3 real quickly, if you look at section 3.0 of your policy, which is requesting or ordering quarantine, this is the language that tries to respond to these tests. Yes, you can still make a judgment call that's wrong, but these are the, 3, it's actually 3.2.2 sub 2 and those that little group there. The first is it warranted? Is quarantine warranted at all? People think it should be warranted for lice, but actually that's not a real dangerous disease. So you look at the agent that a person may have been exposed to. You look at the immunity or susceptibility of, or ways to render immunity, such as post-exposure antibiotics or vaccinations. And you always look at the degree of risk or severe illness or death. So again, you're not going to quarantine for lice, but I'll tell you, more parents will call you and wish that you did. And you call them and say, we really need you to keep your kid home because they didn't have their pertussis shot and they sat with you 3 feet for a whole class in Mrs. So-and-so's classroom. They often don't want to, so that's risk perception for you. So that's your first test, is it warranted? Second test, is it even feasible? Could you, in fact, identify those that were exposed? And if it's not feasible, don't take your eyes off the ball and try to do a mass quarantine. If it's not feasible, focus on the cases and the close contacts that you do have. Another test for feasibility, these are quarantine tents, they're ancient. As I said earlier, we'd never get away with that. Our policy says if you're going to quarantine somebody, you've got to make sure that they have what they need. They need to be in good living quarters, not exposed to others, have their basic needs met. And then a key one is, are people likely to cooperate? And if it looks pretty unlikely that they're going to cooperate, don't try to impose it. Go for voluntary, use incentives, go small scale, do other things. This is things we try to write through in the process steps. Finally, will the benefits exceed the risks? Well, this is a old sketch, and there's actual pictures up into the modern day of people, civil disobedience and actually violence against people or the facility that they are quarantined in. Very common. You can go back in history and you can bring it all the way up to SARS in China when they quarantined in one province, and the people of China in that area started throwing rocks and breaking the windows of a quarantine facility. So that's human nature, it's fear.
Every airport in China has things that detect your temperature and guys with machine guns there, and if you have a fever going through the airport, they quarantine you.
They were
So-
out washing the streets with soap and fire hoses for SARS, like kind of the wrong action, but it looked good. So this is really the hardest test because it's predictive, and you just can't know on some big stuff if it'll work.
Well, and there's the flip side of that too. When you look at the hepatitis outbreak in San Diego, which is likely to go anywhere there's populations of people who are homeless or choosing to be voluntary homeless, they probably should have done significantly more from a quarantine perspective because of what was going on there
Just
too.
basic sanitation in the homeless areas, which they ended up doing.
So when is HIPAA suspended? Because at a certain point, you identify the victim or do you not? Do you identify, if it's something particularly
The only
hazardous,
time
do
you
ever
have to identify
the point?
the people you're trying to quarantine is if you end up in a court case and you can't get it sealed. I mean, we isolate for TB, for example, and even before we developed our public health emergency preparedness, we would often work with the police department to find, go get somebody that was supposed to be isolated that got loose.
It gets tricky with contact tracing if you keep everything kind of hidden and you need large groups of people to help identify individuals, then it gets
You
tricky.
can tell a wife, for example, that she was exposed to communicable disease and never use the husband's name.
Right, but your mandate is public health, so.
Right.
And there's a public
It's
health
tough.
emergency exception to HIPAA, so.
Yeah.
That's why I wondered
It's an
when
exemption to
does
almost
that fit
everything.
in?
So, I mean, it's
But
the one time.
Even if we could legally get away with it ethically and in order to garner cooperation, we would still want to be very private. So we've had contemporary cases. This is measles in 2015. One of the things you asked, James, was our guidance, and I'll show you in a minute our guidance and Cindy's. So this disease, that situation, that was a big outbreak, and that really had a lot of disruption in California, a lot of deaths, in fact, a lot of hospitalizations. It was a policy changer. They changed policies on exempting, personal exemptions, all the way up the West Coast after this measles outbreak.
Well, and there's another outbreak that started yesterday in Newark, Detroit, and Memphis.
Measles?
Yeah.
Yeah, it's from I think it was probably in Delta, because it was Detroit, Memphis, those are the two of the hubs. Yeah. So we have, this is our reference document, Control of Communicable Diseases Manual. Everyone knows this. This is an old copy. It says, do not remove from my desk, I'll tell you. But we also have it in e-form at this, I'll show it to you in a minute. I can't get the link to work. But in every disease, you're going to see what I've highlighted in yellow. Do you isolate? What do you do for isolation? What do you do for quarantine? What else do you do for controls? And I think the email that James sent to me was very good. It's great to defer all this power to some sort of CCDM, but what is it? This is the guidance.
Well, I think that's what the public's going to ask. If we have to implement any of these procedures, I think we need to be transparent quickly with here's the guidance, here's the references, here's the information, this is why we're doing it, because keeping stuff secret is when people get really frustrated.
Right.
And we're in a region that gets frustrated really easy about government keeping things secret.
Well, they think it's like the movies. They think the CDC moves in with trucks and then and that's not what happens.
If I could just quickly add to
Please.
the CCDM actually was added the last time that they did the ARMs in Montana for communicable disease. They changed it so that instead of having the actual, like, here's what you need to do for each individual disease, then the ARMs actually now cite the CCDM as where to reference for control.
Great.
So we've come a long way, but along that way, we've certainly lost our experience and our expectation that police power might be used. And I think that's what we would run into more than anything. So this is quarantine at Ellis Island over 100 years ago. And this is isolation and quarantine in Toronto for a SARS outbreak. So you can see it becomes very disease-specific and situational, very much so. And that's just kind of, I wanted to get those changes in your head. And then I just want to show you.
Well, Americans have had 40-plus years of not worrying about any large-scale outbreaks of anything.
Yeah.
And
the rise of the anti-vaxxers.
And it's not even that. There's drug resistance. There's I think globalization, stuff like SARS, stuff like recombinant influenza.
Doctors would have never seen measles.
There was a reason for that.
People in a pertussis outbreak go to a local ER and get a cardiac workup. I mean, none of us have the kind of experience that people 50, 60, 70 years ago have. So it does require a lot of thinking. I just want to show you the online that we have access to.
Well, I think measles is the most communicable disease known, isn't it, for its N value, if I remember correctly? So
There's nothing.
it's pretty much if you're around it and you're not immune, you're going to get it.
We did
Smallpox was.
It's awful and it's ugly, but measles, we did a measles tabletop, what, 6 months ago?
Last fall.
We did it primarily because I remember the last measles outbreak here, and I thought, my God, all these young people don't know how fast you have to move.
Well, we had
move so fast.
We had a suspected case of measles in the summer that we didn't actually find out about until 6 days after the child was symptomatic. And so that was sorry.
No, I asked you to speak, please.
Okay, I'm Cindy Farm, the Director of the Health Promotion Division, and as such, I supervise the Infectious Disease Office. So we had a suspected case of measles in a child last summer that we didn't find out about until 6 days after he first developed symptoms. And by that point, he had already been to both ERs, a couple of clinics. I mean, if it had been measles, it would have been a mess. And so that was a big trigger for us. We had actually already been talking about doing a measles tabletop, but that was okay, we need to do it like right now because we are seeing measles outbreaks, nationwide, and there's no sign of them decreasing. If anything, we're seeing more and more small outbreaks. So we pulled together a tabletop just to make sure that everyone that we work with in the community, the hospitals, clinics, everyone kind of knows what should happen if they have a suspected measles case so that we won't end up in that position again, hopefully.
Yeah, not gonna So I appreciate your engagement with it, and it gave me the opportunity to go, we haven't really talked about this since 2003. What we were really trying to do with this update is clean up some of the references that Anna discovered had been gotten old and out of date. So it references the CCDM, which we also have online access to. Now, I don't have it at the moment, but you can see all this up there. Our on-call team has access to it, and they're 24/7. It references the county emergency plan and Annex 8. And it also references something else, I think the ARMs. Oh no, our public health emergency plan.
I looked at this because we had kind of a Friday afternoon potential emergency for a quarantine isolation.
Possible TB case.
And I was really surprised. I had never looked at it with how well set out the ARMs are. I mean, every possible disease they have, it's very clear what needs to be done. And then these are crystal clear. So there's plenty for us to fall back on as far as how we make this determination and how it's justified. I mean, it's not somebody just coming up with what should happen. It's pretty well established in Montana law and with this guidance.
I think it's banning a congregation we'd be more likely to run into. Like don't hold that high school softball tournament because you had measles, which is is a form of police power, use of police power, but not really isolation or quarantine.
And truly, in the cases that we've seen and in the incidents where we do need to talk about isolation and quarantine, 99% of the time we can get people to self-isolate or quarantine themselves until we know, okay, we know you don't have the disease, we've made it through the incubation period, or okay, you have the disease and we really need you to, keep yourself at home, don't see anyone, don't have people over, don't go out. And like 99% of the time people are very cooperative because me and our nurses are very good at explaining the risk of, this is why we need you to do it. And so we can usually get people to cooperate without having to actually force them to.
Thank you guys very much.
Thanks for engaging on it. I didn't realize it was this old. I was like, oh my goodness.
Do we need to take any action on this?
Yes, we would.
I would move that we amend the quarantine and isolation measures policy as proposed.
I second that. There's a motion on the table. Any public discussion? Seeing none, any other board or staff comments on the motion on the table? All those in favor, signal with aye.
Aye.
All those opposed, same sign. Motion carries.
Thank you.
I hate to mention this, I've got to get out of here in 15 or 20 minutes.
Mhm.
I have to chair a meeting at 3, so I'm going to.
Let's roll. Pam's up for Maternal Child Health Advisory Council update.
So this will be pretty short and sweet. The meeting was supposed to have someone from the Neonatal Abstinence Syndrome Group there to talk about the updates from there, but there was nobody there. So the rest of the meeting was very loose. We talked about getting Anna Simple in for the May meeting to talk about the abstinence syndrome and the collective impact group. So that is going to be on the agenda next month. Tamara Knotts will be asked to speak about the Nest, which is a home for mothers and children struggling with addiction in St. Ignatius, and they're planning to open a home in Missoula as well, under the auspices of Western Montana Mental Health Center. What's that?
There is one.
There
Right,
is
there's
one,
the
but
Carol
this is
Grant
going to be,
home.
that's the
Another
Carol
one.
Grant home, and this is different. This will be, and it's really difficult to get people placed there, so we need more. There will be a maternal mental health and wellness conference sponsored by Providence St. Patrick's on May 7th that is going to discuss and share research and resources on perinatal mental health issues. And so addiction is one of those things as well. And then the dentists in town had a meeting to address the opioid crisis. And that has never been done before. They've never been asked to be part of the registry, the drug registry. So there was a dentist who spoke at it, the chief of police, and somebody from the health department. And they talked about getting registered and how to get rid of drugs. And so the dentists are now getting on board with that, and they're usually really good about stuff, so I'm sure they will get on board with that. And then there was an update about the targeted case management services, but I think you've covered that pretty well, so I don't think we need to go over that again. So that was it, the end of the meeting.
Thank you.
Short and sweet.
Thank you for joining that.
On the agenda, we're going to defer number 9 until April to get organized for that discussion. Number 10, Director's Report.
I want to thank everyone at the table, James, Dr. Stenger, Julie, Jean, and maybe others of you weighed in when I put out the call for help on the smoking ordinance, when the vaping exemption for the vape shops was looking perhaps viable. Thank you for responding so quickly. Thank you, everyone, including Anna, for working all along. Public Health and Safety Committee, the vape exemption was not added to the ordinance, but some other improvements that we got from the Lung Association of Language and Terminology were added, and it moved unanimously out of committee, and it will be on the consent agenda Monday night at City Council. Then we'll be talking next steps for Health Board and County Commissioners, so thank you. We learned a lot.
Nice way to say that.
I was getting texts from wherever you were in the globe, and
I was in New York.
you were in New York, you were in
El
Latin.
Salvador.
You were in El Salvador, I don't know
I was
where
on
you
a
were.
plane.
I was
Messaging you
just
guys.
on my couch on 6.
But I was like, I know I'm bugging you, but they really need to hear from our experts, and well, you did it. You did it.
I found references like within like 2 minutes. I'm like, okay, I can write an email based on the references I found. Here you
It
go.
was great. We needed it. It changed things.
Is that it?
That's it, thank you.
I'll make the call for public comments not on the agenda. Seeing none, we'll move on to board and staff comments on items not on the agenda. Seeing none, we will adjourn and reconvene as the Air Pollution Control Board. We don't have minutes from January and February, so we'll catch that next time. We have something that we may take action on or may not, which is action to appoint an Air Pollution Control Board liaison to the Air Quality Advisory Council. This is a position that Garen used to fulfill for us. And Ellen, can you remind us when that group meets?
It's either the first or second Tuesday. It's the first
First
It's the
Tuesday of
first
the
Tuesday at 7 in the evening in this room. So when,
It's not me, don't
So-
look at me.
No, so what I was gonna say is, I'll need you guys to help, what's more important for the thing. I either can do the TPCC or I can probably do that one, so depending on where you want representation more at, I probably only have time to do one of the other
that's
ones.
understandable.
Yeah. So TPCC is, remind,
The transportation.
yeah, when do they meet?
We don't want to give up
Oh,
that
it's
seat,
the,
but
Third is next week, the third Tuesday.
Must be the 4th. Fourth
No,
Tuesday.
it's only third Tuesday.
Oh, Tuesday, right.
Or this week was the second.
And they canceled this month.
This month's is canceled, yeah.
I could do it, but Jordan Hess is already on it, so then we'd have multiple city council people.
yeah.
Right. So when,
Someone's moving next.
I'm really hesitant to volunteer for another thing that happens in the evenings.
I know.
But I could do it if we really need to volunteer.
well, I'm wondering, are you more interested in the, is there more interest
He's
in the
probably
air?
better suited for the air quality thing.
I'm ambivalent on either thing, so it's more what would benefit the board, I think, from having me observe
So
something.
I'm wondering about you doing air and me doing TPCC.
I travel a lot, so that's
So do I.
so that's my bigger
It's
concern
okay.
is like.
Any connection is still good.
I cleared out all of my Thursdays as much as I could.
And
around-
staff-
Schedule all my doctor's
staff-
appointments so that then I'm like, oh, I
We don't want to
can't.
lose, a seat on TPCC. It took quite a while to get it.
Yep.
Staff will definitely backfill.
Yeah,
And it's just like they will with the report here if you can't go to either
yeah,
one.
Sarah. So let's do that.
I've got another idea for you, Dr. Steiner.
Air and TPCC. Okay. Okay.
So then we'll need to notify folks at the city of the change from James to Debbie.
Right.
And I did cancel the April one, so, or
Which
the
is
March.
because we have,
So do I need to make a motion to appoint
We
James
do.
Stevens to the Air Pollution Control Board?
Yeah, and you can't make a motion on the other one because we don't have it listed, so we'll, we don't need a motion on either one, it's just that we did put it down, so we
So
can
we should
just,
follow through.
It's a voluntary.
you can just do it by acclamation and we'll make the change.
Okay, let's do it
Okay,
that way.
thank you very much.
Excellent.
Bert isn't here, so I think we'll skip our Air Quality Advisory Council update and ask for public comments on items not on the agenda. Seeing none, carrying on. Board and staff comments on items not on the agenda.
I was just upset that there was an editorial in the New England Journal in the last couple weeks about wildfire smoke, and it was some person from California, and it should have been Sarah.
If she gets too famous, we'll lose her.
She was in the Wall Street Journal.
Thank you very much.
Okay, we will adjourn.